but altogether we should have 160 or so people present for this one way or another, which is pretty amazing. This turned out to be a hard meeting to put together. We've been working on it since July, and it took until just a few weeks ago to actually get it all put together. And a lot of the reason for that was a surprising one. It was really hard to find people who knew anything about the therapeutic area user guides and/or who were actually implementing them at their companies. Can I see a show of hands of anyone at a company who is actually implementing a therapeutic area user guide currently? That's 2 hands, and they're both from the same company. Okay. So, oh, wait. No other hands, but they're just waving at people. So that's actually pretty indicative. The therapeutic area user guide started coming out several years ago, and they and I think the early ones were ones that were not for indications or drugs that were only being developed by companies in industry. They were more for the FDA and CDC's purposes than industry's purposes. Now that's changed, and the FDA has signaled that therapeutic area user guides are going to become required standards. What that means, in short, is that when they put therapeutic area user guides into the standards catalog, that those user guides will then become required standards when you have a study that you're submitting that they're applicable to. You will be required to use the standards from the therapeutic area user guide. And that discussion about exactly how and when that requirement will happen, that discussion is, I think, going on currently, and we're going to hear more about that. So I'm not going to do much more yammering here, but we have a surprise today. We have 2 surprises. One is that Mario Waddell got buried under work and couldn't do his presentation on diabetes for this. However, on the other hand, Becky Cush, the president and CEO of CDISC, showed up. And so actually I'm going to introduce Becky very briefly, and she's going to introduce Rhonda Facile, our first presenter, and then we'll get this thing going. Becky, stand up. Thank you for coming. CDISC has been a great supporter of our activities here ever since we started, which was 10 years ago. And thank you. And I don't think you need much more introduction than that. So let me just turn it over to you.
Thank you, John. And I'd like to thank John because he actually started the very first user network that CDISC ever had. So that's you all. And he's done a great job of keeping this going over the years. We do have, at one time we had about 10 user networks, but some of them have come and gone, and some are more active than the others, and I think John's just done a real nice job of keeping this one consistently going on and getting bigger and better every year. So thank you to John Braga for that. So he asked me about 1 minute ago to do this introduction. So I'd just like to see if some of you are aware of the history of the therapeutic area standards, and I'll ask by first asking you if you know which one was the first one we worked on. So it's interesting, about 5 or 6 years ago, we did a survey of the people who came to the CDISC interchange and asked, about building in value and making sure the CDISC was bringing value to all of the constituents, all of you people and your companies. And we now have almost 2 million people represented in our CDISC organizations, which is, to me, phenomenal. But we said we have to keep bringing value, and what can we do to bring that value? And overwhelmingly, everybody said, basically, do the rest of the standards. In other words, because we had started with what we now call the foundational standards that cut across all the therapeutic areas, people were saying, now what do we do with the data for this specific to therapeutic areas? So we got our first entree and our first opportunity to do that through 2 NIH roadmap grants that were given to Duke. And Duke Clinical Research Institute saw kind of the future in this, and they said, you help us, and they built in, I think, $10,000 in each of those grants for CDISC to help them develop therapeutic area standards. And I can tell you it costs a whole lot more than $10,000 to do, but the first ones were tuberculosis and cardiovascular. And the nice thing about tuberculosis was there was a need, and people really wanted it, and they formed a TB Alliance, which some of the pharma companies are part of, and they started using it for a purpose. And it went much more smoothly than the one in cardiovascular. As you can imagine, that cardiovascular one has all kinds of pieces to the cardiovascular arena. And after going in circles for about a year, they finally said, well, let's just hone in on doing acute coronary syndrome. So that was one of the other first ones. The other ones that happened after that were the one on polycystic kidney disease, which some of you may know just got approved as a biomarker for it helped to approve a new biomarker, let's put it that way, for polycystic kidney disease, because Ron Perone at Tufts University saw that if he could go through a bunch of old data that was at 6 different institutions and aggregate it and see if there was something in there, that he could prove that there was an earlier point at which you could start treating these patients. And that's what they did. So polycystic kidney disease, there's now a paper that's been published that we can share with you on that one. And that was a success. The other one we did through the Coalition Against Major Diseases with the Critical Path Institute. And that was the one on Alzheimer's disease. And now there's a follow-on to Parkinson's disease. So they're building out databases to aggregate data on, especially on Alzheimer's, on failed trials, so that they could see if they could start doing some disease modeling and look for new therapies for Alzheimer's disease, and that's where that one started. So after all of this, PDUFA 5 came out, and in PDUFA 5, it states that we should do the therapeutic area standards. And some people counted it up, and they gave it the name 55 and 5, which has been a real problem ever since that came out, because everybody's like, aren't you going to do 55 in 5 years? And some of those are things like QT intervals, which we thought would be easy, but when you get 2 opinion leaders who don't agree, it's not always easy to get to a standard. But we did do that one. Oncology is one, which, you can tell by the 2 I just gave you that the scope is all over the board. So 55 is not really the way to characterize this. So it's been an interesting road, and when this all came out with PDUFA, we met with our colleagues, the Critical Path Institute, and we looked back at the ones we've been working on, and we have Enrique has a slide showing the flip chart that we worked on all afternoon one day to try to figure out how to improve the process around developing therapeutic area standards. And after that, Rhonda went home and turned it into something that everybody can actually read and use, and it's a process that we're now using, and she keeps improving it every year. So I'll quit going on about this, although I could probably go on for longer. As John said, I could figure out something to say. But I can't say enough nice things about Rhonda, and she got started in CDISC when she decided to move home from Sweden, and she had lived there for a number of years, and she keeps reminding me, I can't remember if it's 10 or 15, but she was in Sweden for quite some time, and she called me and said, I'd like to work for CDISC, and I said, well, that's great, I'd love to have you, but I don't have anything for you to do and I don't have any money. And so about 3 months later, it turned out that the FDA got together with ACRO and pulled us in, and some of you are aware of the critical path document, which is Innovation versus Stagnation, which Janet Woodcock and Mark McClellan wrote. And there were some opportunities in that document, and they basically asked us if we would take over creating case report form standards. And they handed it to us. Again, we didn't have any money, and they said, I'm sure you'll find some money, I'm sure you'll figure this out. So I called Rhonda and I said, okay, I've got a project for you. And I started explaining it to her, and she said, this is big. And I said, yeah, it's big. And she didn't bat an eyelash. She spent the next 2 years, she organized, and she was the one who spearheaded the development of CDASH with all volunteers, and Rhonda was the only staff person. So I found enough to pay her salary and a little travel, and that was how CDASH happened. And so she's single-handedly responsible for that standard. She went on to do a lot of the groundwork that's behind SHARE, and when CFAST came on board, she picked it up and ran with it. So she's the best person to talk to you about what's been done on the therapeutic area standards and where we're going, and I'm really glad that we could have her here today.
Okay. Well, good afternoon, everyone. Well, first I need to start by thanking Becky Cush for that delightful presentation. Really appreciate it. But it took a tremendous and large team in order to pull that off, you know, getting all of those 16 domains developed, and maybe even some of you in the room had something to do with that. So it was a really good experience, and I think we did move the bar forward a bit. Subsequently, there's been new versions of CDASH. There's a 1.1 and there's a 2.0 under development now, so hopefully that'll be ready soon. So thank you very much, and thanks to John and the folks at the Bay Area User Group for inviting me to come and present to you today. So yeah, I've been with CDISC for a while, and it's been very interesting and very, you know, I've learned a lot over the last couple of years. Originally, I'm not a data manager. I came from the clinical side, so I was a monitor and I was a clinical project manager and things of that sort. So if you came looking for SDTM implementation advice, I'm not your woman. But if you want to talk about this project and what we're doing and some of the details around the delivery, I am here to tell you about that. I would like this to be pretty informal, so if you have any questions, raise your hand or come to the mic and we'll take them as we go along rather than waiting until the very end.
Rhonda, may I interrupt you for a moment? This is Nikki.
Sure.
John, would you like our attendees online to provide questions in the question boxes there that we might be able to cover in the end? Or do you have any rules about questions, any other rules about questions?
For the online attendees, why don't we accumulate them, and then you can ask them when Rhonda's done with the presentation. Is that okay?
That works for me.
Okay.
Thank you.
Okay, great. So here's the agenda. Just a little bit about CDISC for those of you that are relatively new. I don't have a lot of slides on this because I'm assuming that you all know about CDISC. Then we'll talk about the CFAST Initiative, the history, the governance, and how we're getting work done. I am going to survey the TA development process briefly because I think it's really important that you all know that we have a robust process that ensures that we get review and input from the appropriate parties in developing the standards. We'll touch on CDISC Share, how that's the target for all the metadata we're developing, and we'll talk about the FDA specifications project that Diane Wold is leading. It's really important to the project going forward. I'll walk through a TA user guide, and I think some other presenters, Anita will probably give you more details about what's in the breast cancer therapeutic area standard, but I'll give you some examples from the diabetes document. And then, really importantly, I think we'll talk about what we've learned so far and where we're headed the next year, and then a little bit about how to get involved, even more than you already are, and I'll tell you about the Fellows Program in case any of you are interested in that. So before I go any further, I just want to say this is an acknowledgement slide. This slide set has been shared and developed by numerous people. You know what you do. You have a slide on this, you have a slide on that, and then you put it together. And this is what I've done for this presentation. So I have to say thanks to Becky, Diane, Rachel Zirkle, and Wayne Kubik. So what is CDISC? I mean, you guys know a little bit preaching to the choir, but we're here to support electronic acquisition, exchange, and submission and archiving of clinical research data and metadata. And we do that because we firmly believe that this will improve data quality and streamline medical and biopharmaceutical product development and research processes. All the standards are consensus-based. Not everybody agrees with the solutions, but they can live with it, and that's got to be our goal going forward. Well, it has been and it will be going forward, rather. All the standards are freely available on the CDISC website, and it will always remain so. You can always go there and get a PDF. Now we're working with Share, and there will be other ways to access the standards electronically so that they are consumable more immediately. But we will always maintain the free standards in PDF version on the website. The IP policy that CDISC has ensures that the standards are open and free. So a little bit about CDISC in general. These little circles here tell you about the different communities. We have the CDISC Advisory Council, the CDISC Board of Directors, CDISC Coordinating Committees, of which this is one, a very important one. CDISC Operations, which supports all of these groups, CDISC Teams, and then CDISC User Networks, or rather this is a user network. And then we have the members, supporters, volunteers, stakeholders, and adopters. So this is a really important slide, and as we're moving into therapeutic area standards development, it becomes even more important when we're dealing with academics and clinicians. This is what I call the disclaimer. CDISC standards specify how to structure the data to support efficient data sharing for regulated clinical trials. What we do not do is specify what data should be collected or how to conduct clinical trial protocols, assessments, and endpoints. So just a really important thing to keep in mind, that we're not dictating or trying to describe medical science. We're not trying to tell physicians what they should be doing in their clinical trials. But we're here to say, if you do collect it and if you do use it, model it like this. Use these standards. Use this metadata. Does that make sense? Yeah? Great. All right, so a little bit about CFAST. Well, not a little bit, a lot. So it's about patients. I mean, really, this is what it does get down to, is the human issues, and that whether we like it or not, all of us either are or will be patients at some point in our lives. And so the work that we're doing with the TA standards, to be able to marry that together with the safety information, will get us to where we have the metadata that will make development go quicker and better and faster, and in the end help patients. So CFAST, it's an initiative of CDISC and its partner, the Critical Path Institute. And I have to say that the CPath folks are wonderful to work with. They have been instrumental in the work that we're doing on CFAST. And we all agree it's to accelerate clinical research and medical product development by facilitating the creation and maintenance of data standards, tools, and methods for conducting clinical research and TAs that are important to public health. So this slide kind of shows you the collaborations and the governance structure of the CFAST program. On the left there, you have the CFAST SAC, which is the acronym for the Scientific Advisory Committee. And that's made up of CDISC, the Critical Path Institute, the FDA, Transcelerate Biopharma, ACRO, NIH, and the European Innovative Medicines Initiative. And that group provides scientific advice for the steering committee that I'll tell you about in a moment. It identifies risks and opportunities and helps to ensure that we identify and engage relevant partners. We always need clinical expertise on these projects, and that's just one of the areas that the Scientific Advisory Committee helps out with their network and identifying experts to help on these projects. On the right there, you have the CFAST TAPSCI, which is the Therapeutic Area Steering Committee. And that's made up of representatives from CDISC, again, the Critical Path Institute, FDA, Transcelerate Biopharma, and NCI. And that group is responsible for the day-to-day operations of the project, at least the high-level ones. They prioritize and approve proposals. So if any of you are interested in submitting a therapeutic area proposal, if you want a particular therapeutic area developed, you can submit a proposal and submit it to the steering committee, and they'll have a look at that. And it's given even more weight if you come with resources to help to make that happen. But the TAPSCI, they also approve the projects and the charters. Every project has a charter that has to be completed, and part of that charter is not only a list of the indication and the team members, but also a general estimate of how much work needs to be done. You know, there's initial gap analysis there, comparing the general medical concepts for that TA to what we already have in CDISC standards and just trying to figure out how big of a project are we talking about. Are we talking about a Chihuahua or are we talking about a Golden Retriever? I'm just checking to see if you guys know Scrum. Have you guys read the Scrum book? Yeah, so you know what I'm talking about. Yeah, good. They also, helps to identify resources, and this is general oversight of the project. So this works. I mean, this is year 3, and it's worked really well. But underneath that, we've got this other layer here, and this is a bit more complex. This is the project organization and roles. And what we're dealing with here is a whole new set of roles, and I'll talk about that a little bit later in my presentation. But here's the project organization. Starting from the top, we've got the CDISC Standards Review Council, and that's a group of experts. That's a CDISC committee, and what they do is they review and approve all of the CDISC standards before they get published on the CDISC website. And the purpose of this group is to make sure that we don't contradict or break any of the published standards. So it's a very important committee. What we're going to do in the future, right now that review kind of happens later in the process, but we're moving it earlier in the process so we know for a fact that the modeling is correct. But it's a very important committee. And underneath that, you've got the SDS team, which is the group that develops the study data tabulation model, the SDTM, the CDASH team, the ATOM team, and the terminology and QRS teams. And these are we call them the foundational teams. They're the ones that have been working with us the last decade developing the foundational standards. So moving to the right, the darker blue boxes, the CFAST TA steering committee, or the TAPSCI, and then we have the SAC there on the right that provides advice to the CFAST steering committee and supports the teams. But the first box there under CFAST TA is the project level roles, and that's the project manager for a particular TA project, the TA clinical experts, the TA stats expert, metadata developers, CDISC team representatives, and then a medical writer. And as you can see, all of those, they have to work together with the foundational teams in order for this to work, right? Because we want to have the safety stuff together with the efficacy stuff. And then on the box, the column on the far right there is more the overall project roles. And there you have the program manager, which is me, the modeling expert, which is Diane Wold. We have terminology and QRS experts, Bernice Yost and Aaron Mulbrat from the NCI EBS. And then we have a couple of technical writers that also help to make sure that the documents are of good quality. Then on the bottom there, you have the review community. That's all of you in the room. You're part of CDISC. It's also CPATH and their stakeholders, the FDA, various divisions that are involved in a particular therapeutic area, and I'll talk more about that in a moment. And we also have the PMDA from Japan, who are very engaged in the CFAST project and actually want to create a mirror CFAST organization in Japan. So we're just now working with them to create those pathways and also to see if we can bring them in for an ongoing therapeutic area project. So rather than wait until something is published and they have a look at it, but to actually bring them in on an ongoing project and get their input. There can be cases where a particular therapeutic area might require some additional data elements for the Japanese population, so I think it would be really cool if we were able to do that at the same time. Just some thoughts for the future. Also part of the review community is the Transcelerate Biopharma and then the key opinion leaders within the particular therapeutic area. And here again is where SAC helps out with that a lot as well, and also Transcelerate Biopharma to make sure that the right people are looking at this. We're also trying to target medical associations. I mean, for diabetes, I think we worked a lot with the American Diabetic Association, and really trying to make sure that we get this in front of the right people. We also work with the U.S. National Institutes of Health. We go through their BIMIC, which is their committee that kind of sits above the different NIHs and kind of coordinates CDEs across the different NIHs. So they're involved. And of course, anything we do in oncology, we're together with the NCI because we've been working with them for so many years. It goes without saying practically. And others as needed. For this to work, there has to be collaboration and feedback throughout. And if I was going to draw arrows, that would be a really sloppy slide because everything's pointing all over the place. But we just have to be sure that, that we send it to the right people and get it vetted and that we get that feedback that we need. So this is very complex. A lot of people are involved in this, and communication is key. So a little bit of history about the program. I'll just add a little bit to what Becky told you. It was launched in 2012 by partners CDISC and CPATH. The SAC initiated in 2013. The first project under the asthma, under CFAST rather, was the asthma pilot project that Diane Wold and I did with the asthma team, and I think that's probably the standard that our colleagues at Roche implemented. Is that right, Jonathan? You almost did. Okay. Maybe I'm thinking it's AstraZeneca gave a presentation where they had an 80% overlap with their internal standards for asthma, which was a pretty good result, I think. Thanks, Jonathan. Caught you off guard on that one. Yeah. So during that asthma pilot, we enhanced the development process. We also introduced new roles, which I'll tell you about shortly, and also this idea of a TA user guide. What should that contain, and what should it look like? And we did our best guess at this at that time. We also piloted this idea of using concept modeling, as a way of having that conversation with the clinician, of showing them a picture and going, is this how you do it? And they go, yes. Or they go, no, this is how we do it. And then we change it. And that conversation kind of facilitated making sure that we understood the key clinical concepts well enough to map them into CDISC standards, or at least to identify where there wasn't a match and it was something that we needed to develop. We also piloted metadata displays, and I'll show you what that looks like a little bit later, and we included SDTM. The goal is to expand the content to develop to developing concept level metadata and actually getting us to end-to-end metadata. By the way, how many of you are working on developing end-to-end metadata in your companies? Okay, 6. No, you're just scratching your head. I don't count that one. Okay, all right. Yeah. How many of you have succeeded in doing it? Yeah, that's what I thought. It's really hard, and there's lots of reasons for why that's hard. But we're starting to slowly chip away at getting to end-to-end metadata, and I'll talk more about that in a moment. Okay, working principles, and it's really important that we have them because people, when you get them on teams, especially with clinicians, they want to include a lot more than just the core things. So it's really important that we had a few things where we can tell them, here's the scope, this is what we're going to focus on for this first version, and we'll expand it later, once we get a stake in the ground for the first version. So the first thing is that we focus on core concepts that apply across all phases of clinical trials in a specific TA. So this is the exact same thing we did for the foundational standards, CDASH in particular. What are those things that you're going to recite on every single study that you do? And that's what we applied here. I like to call it the MVP. Actually, I stole this one from Sam Hume. I love that. Minimum valuable product for first versions. Have you guys heard of that one before? Okay, good. Well, here's one for you to use in the future, right? We also wanted to minimize the text where possible. I mean, we all know that comment fields are not good to have on a case report form, right? Because you can't manage those in a database. Anybody agree with me? Yeah. Well, we don't want to have it in these TAs either. We want to have minimal text in these TAs because it causes a host of other, unexpected problems when you have too much text. But also, too, the idea here is to focus as narrowly as you can on what it is you want to communicate and just communicate that without a lot of extraneous text. Actually, Becky and I were talking before we started the meeting about working with Japan and about translations, and oh my gosh, here's the 400-page SDTM IG 3.2. To translate that, 400 pages, I'm not sure I'd sign up for that, would you? It's a big job, yeah. So we need to minimize text where possible. Focus on explaining the concept maps and the metadata and the examples, and row captions and things of that sort. The other thing that we want to do across all these projects is to use share ecosystem tools where possible. So as the share team pumps out a new tool, we evaluate how we can use it on the CFAST projects. And I'll tell you a little bit more later about the prostate cancer project, which is really where we're bringing these two together. We're bringing the share group together with the TA content group, and we're really trying to leverage the tools that they have to make this go quicker. And we always want to use content to reuse content to assemble packages. If there are perfectly good SDTM domains that can be used, in the case of breast cancer, we've got all those tumor domains in SDTM. We're going to use them, and we're only going to develop the things that aren't covered in current standards. Does that make sense? Great. So the published standards, I was just going to tell you guys that as of yesterday, the CFAST project has published 17 therapeutic area standards guides. And this is from 2013 and includes the ones that were developed before CFAST. We have 17 ongoing projects, and we have 5 TA user guides to be published the end of this year moving into 2016, and we have 7 more to start next year, and I'll show you a list of that soon. But if you want to find the published TA standards, you go to the CDISC website and click on therapeutic areas, and you have that little green box there lists all of the available TA standards, and you can just, I think it's linked, you can just click it, it'll take you to a Word document or a PDF. Alternatively, you can just scroll down the page and you'll see each one of the standards is described under that page. So here's here's an overview diagram that we post this on the therapeutic area page as well, and it lists all the ongoing projects. I'm not going to go through all of these in detail. You can go up to the website and have a look yourself, but I just want to let you know that. So here towards the end of this year and moving into 16, these are the ones that we're going to publish. We actually published traumatic brain injury yesterday, which was a huge win, a completely new therapeutic area for us, and the folks at the OneMind organization were thrilled with this. This is a step towards developing other TA user guides within this area as well. I think next they're going to look at post-traumatic stress syndrome, but put a little stake in the ground with traumatic brain injury. The diabetes supplement the diabetes atom supplement is going to be published here soon, as well as COPD. COPD is imminent. I just found out, was it yesterday, that we've got, this is a testament to human nature. There was like 15 comments on COPD last week. And then right before it closed, all of a sudden we had 69 comments. So people are definitely waiting till the last minute to submit their comments. But we're really glad that they're commenting on it. It's a really good thing. Breast cancer as well, that public review period closed Wednesday, and it went from 15 comments to 51. So, you can never get around human nature. People wait till the last minute. Yeah. But again, really good, because we were a little concerned because only 15 public review comments might not be enough to publish it. We needed more. So now I think we have a significant number we can move forward. So then moving into next year, we'll release a therapeutic area user guide for diabetic kidney disease, and then a tuberculosis V2, which will follow on to the V1 and enhance that standard. Okay, here's the pipeline. So here's the list that we're working from. And if you just focus on the orange box there, it includes both the 2015 in-process or planned starts. And as you can see here, the ones that we have that are ongoing now is prostate cancer, which I mentioned a few moments ago, major depressive disorder. We're also looking at general anxiety disorder and bipolar. So we'll see if those are close enough that we can actually develop those in tandem. We'll try to do that. If not, we'll push it off and do them one after the other. We're just still in the process of kind of evaluating that. Solid organ transplant, specifically kidney transplant, is just now started. And that's going to be managed by Critical Path Institute. And I'm the stand-in project manager for colorectal cancer. So the idea is as soon as we finish breast cancer and get that published, we'll focus on the prostate cancer project and working with the SHARE group. And then we want to roll over those lessons learned and the new things that we're doing with SHARE into the colorectal project. And so going into 2016, there's going to be another oncology project around lung cancer, psoriasis, Duchenne muscular dystrophy, and then CDAD. I don't want to read out that whole thing. You guys can read it for yourselves. And postmenopausal osteoporosis, and then finally skin and skin structure infections are on the list for next year. There could be others added. We also have another 5 projects that we're working on that we call specialty area projects. And those are under the CFAST umbrella, but they don't really have the resources to do those. And those are really fascinating projects that deal with global health needs. Things like we've got the Ebola project. We've got malaria. We also have a really interesting new project that's basically managed out of Europe around nutrition. And so that's a new area for CDISC to get involved in. And we've also got the BioVaccine Safe project, so they want to publish a vaccines V1. So there's just some other activities that are also going on that we're trying to push forward using volunteers while we're also pushing forward these CFAST projects. Any questions on that? No? Okay. Okay, so just really briefly about the standards development process. This is a process that really CDISC has had this process from the very beginning. And what we've done with it for the TAs is we just kind of enhanced this first row here, just added some official, more required scoping and planning stages, the identification and modeling of research concepts, and this draft standards piece. But we always have the internal review and the public review before a standard is released. So just a little bit more detail around that. So for scoping, this is really key on the TA stuff because we have to manage, just exactly what it is we're going to develop. Otherwise, if we don't stick to it, we'll definitely not meet the timelines. And the general timeline for these is about 10 to 12 months. Sometimes it's extended a little bit longer than that, and usually it's for a really good reason. Like we didn't get enough comments, or we're waiting for FDA to submit some comments or things of that sort, but we try to stick to that. But when we set the scope, we want to do enough that's useful, like I said before, the minimal viable product, and not too much to be sure that we can achieve that 10 to 12 month duration. The other thing that we must do is identify the regulatory and clinical guidelines that are relevant for a particular TA. I'm sure that makes total sense. We involve the clinicians, and then we start with system independent concept maps, and we try to describe where does the data come from, what are the data items, and what do they mean, and how are the data items related. So that's the focus of scoping. So now we move to stage 2, which is concept modeling, and there is where we start to develop the biomedical concept metadata. It's based on the bridge model, so to provide underlying consistency. It includes CDASC and SDTM, and it includes controlled terminology values and subsets. It's at this point that we develop the implementation examples and then create the user guide, the TA user guide modules. And then we follow the CDISC review process where we have this internal cross-team review that I described earlier, and then this more broad public review where everyone is invited to comment. So this is getting back to that idea about beginning to end metadata. The first CDISC TA standard was tuberculosis, like Becky mentioned, in 2012, and it was a supplement to the SDTM implementation guide. It was organized by SDTM domain, but there was no mention of any other standard. So the CFAST TA project expanded that to include other standards. So asthma, like I mentioned, did SDTM, prototype biomedical concept metadata. Diabetes, the diabetes project brought in CDASC. The QT studies project included ATOM examples. And schizophrenia includes trial design examples. And so what we're seeing is that over time, we're adding more content to the TA user guides. So we're working slowly towards end-to-end. So this just kind of depicts what I was just talking about. So what are we doing? We're adding depth. The biomedical concept metadata, it's a small package of relevant variables and terminology for a particular concept. And it includes CDASC prompts and question text, the SDTM domain, and the test and test level, and the computational method if applicable, for example, BMI. We're also including a subset of relevant controlled terminology. And the idea is that all this is going to be curated in the share metadata repository. And as it stands today, we have all the foundational standards are in the share repository, and a good chunk of the TA metadata is also there as well. Which brings me to share. How many of you have heard about share? Yeah, that's what I thought, more people. Good. So this is just a little bit of how we envision share to be. It's the single trusted authoritative source for CDISC standards. It contains concepts, metadata collections, relationships, those things that I just described. And it also links research to healthcare concepts to support interoperability. And it's aligned with the NCI semantic systems. And so this is a picture that Sue Dubman drew, and I just kind of borrowed it. I thought it was good. But the idea is to facilitate data exchange, access to data standards, source to target mapping and traceability, and transformation logic. So when we talk about share within CDISC, we talk about the actual repository, but then we talk about ecosystem tools, and we're deploying a lot of those on the prostate cancer project. The first priority for share was loading existing standards that I just mentioned a moment ago, and then currently CDISC development teams are benefiting from share by being able to use consistency checking, version comparisons, or diff files. Maybe you guys use that terminology instead. We also have, a quite extensive catalog of domains, supplemental qualifiers, and also we're starting to, develop a long set of examples and pulling them out of the TAUGs and making them so that you can access them by looking across the different domains. We think it'll be very helpful. And of course, SHARE will be the repository for biomedical concept metadata. So what else will it contain? It'll have concrete machine-readable value level metadata, and we have that to some extent now. We're adding new content to it all the time. Implementation use cases, here are a few: building protocol schedule events, automating CRF creation, automating database creation, automating tabulation creation, tabulation validation, and metadata-driven analysis. So what's the impact on implementers? Why should you care? Today, you extrapolate for data, not in implementation guides. That's what you have to do. Connect up separate standards. You're doing that internally, right? And you have to figure out yourself how to pull together the right structural and terminology elements. But in the future, the standards will cover more content. The TA user guides and biomedical concept metadata will integrate across the standards. And it'll be downloadable, machine-readable, and immediately ready to consume in your systems. And the other big thing with this, too, is that, I talk a lot about culture within CDISC, because what we have to do is we have to change from the way we've been developing standards in the past, where one team worked on SDTM, and they're very good at it. One team worked on CDASH. They're experts on the collection piece. One team is working on control terminology, and yet another on the ATOM endpoints. And so what we're getting to is that instead of having these different siloed teams, is to knock that down on its side and go, okay, blood pressure, what does that look like in SDTM? What does it look like on the case report form? What are the control terminology sets for that? And really kind of upend how we're thinking about standards development, and that's where the challenge is. And I think if we can do that, and if we can do that efficiently and effectively, the standards will be much more powerful and much more useful to you all in this room going forward. But we need help. It can't just be us and a few people doing this. We need you all to help with that. So when these standards come out for review, look at them in that context, that you have the chance to impact what that's going to look like and make sure that these things make sense going across. I'm totally fine with doing a V2 and a V3, but if we can get it right on the V1, isn't that great? We're talking big reduction in time spent in having to redo things or do things over and over. And the other thing, too, is that I talk a lot about is not be afraid of making mistakes. I mean, we're not going to get it all right. We're not. But if we work together and do the best we can and then be quick with making the adjustments and fixes, we'll all be much better off. The other thing, too, that we're going to do is instead of doing versions that are like related to a paper document, we'll be versioning on the concept level, which means if something's not right, we can go in and issue a new version much more quickly without having to reissue another point version of a PDF document. Does that not sound cool? I'm trying hard up here, you guys.
So cool.
So cool. And, a lot more fun for us who are trying to identify them, but a lot more fun for you guys who have to live with the product, right? So if you want to know more about SHARE, I'm certainly not an expert on it, but Sam Hume and his team, and we have a new fellow that just joined us named Michael Ibarra, who's also going to be working on the SHARE team. They can answer all your questions. So feel free to send me an email. I'm happy to send it off to people who really know what they're talking about. You can also go to the website and click on the SHARE video. It's delightful. It's a short explanation. It's great for non-technical people, too. So if you're trying to convince higher-ups in your organization about explain to them what this is that we're doing, you can start by clicking on that video. It's a conversation starter, and it's entertaining. You can also visit the CDISC SHARE website. I just put it up here. It's up on the website. Okay, so now I'm going to leave SHARE, and I'm going to kind of pivot to another really important topic. It's the FDA TA Standards Acceptance Project. And let me just say that when we first started with the asthma project, I mean, we were just doing what we thought made sense. And we did have feedback from FDA, from that particular division, and they didn't voice any concerns about the standard. But then a year and a half later, another review division looks at it, and they see some things that they would like clarified. And we get to a point where we realize that what we have here is we have two different audiences that we need to develop standards for. So the first one on the left side here is the normative, for those of you that are, database geeks. But it's TA specifications that are, they're machine readable, and what we want to do is develop normative standards to be included in the FDA standards catalog. And so, and that compares to the non-normative part, which is what we were doing with the initial CFAST TA user guides, is that we were thinking, if I was a data manager, what information would I need? Well, okay, we would need implementation instructions. We would like to have the concept map so we are sure we understand the concept right and the explanations, and we want to have examples because that way we can really see and really see what it is we're supposed to do. We want the SDTM controlled terminology and other examples so that we can do our implementations, right? And then we have these other pieces, the appendices, the glossary, the known issues, the references, and things of that sort. So that's for a data manager. But FDA does not want to put examples in the data standards catalog because people have, there's a tendency to look at the example and go, that's what FDA wants, that's what I'm going to do. But that's not what they should be doing. This is merely an example. So we had to separate out the normative and the non-normative element. That's what we've been doing the last few months and working with the FDA reviewers, Ron Fitzmartin and his colleagues, to really nail down what it is that they need for the data standards catalog. So the items on the left here are the things that they need for the data standards catalog. That would be new domains and variables, specifications, domain tables, the standard and non-standard variables, the rules, control terminology. They also want the known issues section, and eventually this evolution to this connected up biomedical concept metadata over time. Does that make sense? Any questions on that?
Can you give us like an example of what you mean by biomedical concept metadata?
Yeah, but I need a much longer presentation slot. We'll have to get to that a little bit later. But now I want to show that Excel sheet, so let me just escape out of this. Now I'm going to mess everything up, John. So I need to do that, and then...
And then down at the bottom, there's an icon for Excel.
Yeah. This one. Yeah. Okay. So this is an example spreadsheet that Diane Wold has put together for a specification. And it contains these elements, a README file. So this kind of explains the standard, comments, the domains that are used, etc. And then a summary. So this is kind of an overview of the user guide. Here we have on the left in column A, we have the different sections. We have the content, what's in this. This one is from breast cancer. So it's got diagnosis, staging, pathology, molecular measurements. I'm not going to read all of those. I just want to pique your interest with this. If you want to see more, you can come talk to me afterwards. SDTM domains used, new domains that we're creating that don't exist right now, terminology and examples. Great. I wanted to know what time it was. Known issues? Fortunately, there aren't any on this one. It's perfect, yeah. And then here's a little overview of the domains. So we have the domain code, the domain name, and then what they are going across the different versions of the SDTM-IG. Okay, and then on the variable level, we have the variable label, data type, controlled terms, and then this is, a list of what's contained in the different versions, the non-standard variables or subquals, and the standard variables. And then finally, SDTM diff domains. So what are the differences? So this is what we're going to produce for all of the standards. So we have to go back, so for all the published standards, we have to go back and create these FDA specifications. And then for the ones that are ongoing, we need to include this in our process and develop them in tandem. So this is really good. I mean, I think it's a really useful thing too, and that, now we have a point around which we can have good conversations with FDA. And the good thing about this is that it's going to be, the goal is for this to be accepted across all the different divisions within FDA. So it's another deliverable for the teams. It might extend the development period a little bit, but not too much. But I think we're making great progress with this, and this is really a value add. Okay? So, where do I find my presentation? Is it down here under PowerPoint? I just hit that again. Oh, here we go. Great.
And then back to.
Oh yeah, presentation mode. Okay, got it. All right. Okay, and these are just screenshots from the same thing I just showed you in Excel, so I'll just move on. And so here's the plan for, creating these going forward. The first one that's going to be finished is going to be for dyslipidemia, and the goal is that FDA accepts it before the end of the year. So we could just get one through the goalpost before we change the year. And then after that, we'll probably focus on some of the other ones: QT studies, hepatitis C, diabetes, and tuberculosis V2. And that little chart there shows you kind of the plan. CPATH is helping out a lot with developing these or creating these TA specifications.
So these are the first ones that are going to go into the FDA standards catalog?
Yeah. Yeah. This might change a little bit, but I think, in general, we have to get this done, and we're going to get the published ones done as soon as we can.
So the QT studies one, that's going to affect everybody, right? Because everybody's got to do THT studies.
Mm-hmm. Yeah. Yeah. It's really important that we, Becky mentioned that, not all the TAs are equal. I mean, some are easier than others. Some are just lab-based. Dyslipidemia is only lab. Breast cancer is a huge volume, and Anita will tell you more about that. So they are not, it's not a one-to-one thing here. They're all very different. But we need to move away from worrying about how many we publish per year and focus on making sure everything is connected up and correct and implementable. And we need to hear about implementation issues as soon as possible. So as you all are working with these TA standards, you need to let us know how it's going and what you need so that we can make the changes and make it more implementable and easier to use. Can you guys do that? I mean, because otherwise it's just an echo chamber and it's not as good as it can be. Yeah, I know. I'm known for being a positive cheerleader. Okay, the other thing I wanted to talk about today is because of all these challenges to develop these TA standards, CDISC is changing. We're evolving tremendously. We have evolved, and we will continue to do so over the next, always probably, but definitely in the coming year, is that we're evolving into an organization that has a rather robust culture of learning, because we need to bring people in to help to develop the standards, because guess what? A lot of the expertise to do these things resides with you, and we are charged with coordinating that and developing the standards and moving things forward. Slowly we're bringing expertise within the CDISC and trying to make sure that we can cover some of these things, but ultimately we have to do this together. Otherwise, we're just developing standards off on our own. So here's the culture of learning that we've kind of developed over the last year. We have this cycle of assessment and feedback, and that's always been the case with the review periods that we have, the internal and the public review. We do lessons learned, at least at 2 points during each of the TA projects, and we evaluate what's working and what's not, and we definitely have the courage to make needed changes. Group interaction, very important. The use of dialogue and skillful discussion to draw out an intelligence that is greater than the sum of an individual member's talent. And this is a key thing, too. We need to hear from everybody's perspective, because each of you has a different set of needs that need to be taken into account in these standards. We have coaching. We have expertise in-house now to help to coach. We have CDISC experts. We have the SRC, and so that is really robust. We also have forums where if you want to learn concept modeling, you can bring something you're working on to the concept modeling forum, and they'll review it for you. And that's something any of you can do. We also have a metadata development forum, so if you have questions around developing metadata, you can bring it to that forum and get questions answered. And we do this on all the TA projects. We also have a robust set of best practices. I'll show you the list in just a moment, but step-by-step how-tos, how to develop standards, and also a host of checklists and things that will help to make the process go quicker. And finally, now we have Share, which will help us a great deal in doing this quicker and better. I mentioned new roles. These are the roles that we use on these standards development on these projects, but these are something that didn't exist a few years ago within CDISC, but the TA clinical expert, we must have that going in. Now we have a role called metadata developer, metadata curator, and modeling expert, and then we have a share programmer as well. So CDISC is growing to meet the demands of this new approach to developing standards. So let's see, here's just some information about the different tools. I think I'm running long on time, so I'll just kind of go quickly through that. So here's the purpose of the team, and I think we'll zip these up and you guys can have a look at those. I'm not going to read through them. The Metadata Developers Forum is another one that we hold, and then the Concept Modelers Forum, which shows you how to produce these really nice concept diagrams. And again, this is just, it's heuristic. It's just meant to be a tool where you can show someone and go, is this right? And they can go yes or no, and you can tweak it till everybody understands and has a visual picture of a particular clinical concept or process. This is the tools that we have for TA and foundational studies. I won't go through all those, but you can see it's quite a robust set now, and those are all available up on the CDISC website. So if you want to have a look at that, you sure can. And the other thing that we're doing is, because we're doing so much work in a particular TA area, we're starting to develop oncology development plans, for example. This is one that John Owen did, and basically it maps out the TA user guide. In this case, they're looking at treatments, tumor identification, and disease response there. And you know, this view I think is really useful. So when we do the next oncology project, what we'll do is just continue this and hang off more of the things that we're focusing on. A lot of this is becoming repetitive because you use the same type of, you use RECIST in practically all tissue cancer assessment. And Anita can talk more about that later. And I know that you do this within pharmaceutical companies. You have clinical development plans for a particular TA, and we want to do the same thing here so that we are as efficient and effective as we can be. So a quick orientation to a user guide. So this is an example of SDTM metadata, and this section will contain an introduction, a list of patient-directed resources, SDTM domains, and SDTM metadata examples. It's also going to include concept maps, which I've already spoken about, so I don't think I'm going to go through this again. And here's an example of C- annotated CRFs. These are from the diabetes standard. This is for hypoglycemia. But the TA standards will contain annotated case report forms that look like this, and they will also include C- metadata tables that look like this. And there you see the normal collection metadata, question text, prompt, variable name, core designation, etc. And then here's an example of what we call share metadata. And what's circled there is, on the left is the bridge mapping, and then we've got, I can't read it that well. Yeah, anyways, that's the share metadata that's going to go directly into the repository. All right? And so lessons learned. It's been a really interesting couple of years on this project. And you know, we firmly believe that the TA standards development will drive and is driving development of most CDISC standards. Attention to scope is essential. I mentioned that earlier. It's really important. The other thing that we notice is it's much better to point to reference material and not repeat it. We can just tell people to go look at, you know, provide a link to some other place that has the information. But the other thing that we've learned is that smaller, you know, experienced resource teams is really the way to go. We need to have focused clinical input, and then we have, you know, this larger review community input at internal and public review. It doesn't work if you have 30 people on a call. Most people are multitasking. It's better to have a few that are really engaged, pushing the work forward, and then to push it out for a large number of people to review. So where are we going? Well, you saw the list coming up for next year, so those are the projects we're going to be focusing on and finishing, the ones that are ongoing now. But we're going to continue streamlining and modularizing the TA user guides, focusing on core information. We're developing the standards now using the wiki, so we're moving away from developing Word documents, and hopefully we'll also be able to export that during the internal and public reviews, and you all can comment using the wiki instead of the portal, which is a lot easier going forward. So we're working on making things easier for you to participate in developing these standards. We want to use pre-populated templates whenever possible. We have a good set of them now, which we didn't have a couple of years ago. And like I said, we're starting to see a lot of repetitive content and things that we can leverage from previous TA projects. We must produce these normative specifications that I spoke about a few moments ago for all the TA user guides, because, you know, these standards must be included in the FDA standards catalog. You want to update published TA user guides, probably point versions, to remove draft domains. Initially, we included draft domains, but now we need to pull those out and put them up on the wiki. Like I mentioned before, we want to extract the examples and load those into share, and like I said, continually note and reflect and observe on what's working and what doesn't work. So that's where we're going. So how you can get involved. You can join a TA working group, and I hope you do. You can comment on draft standards, both at the internal and public review. You can attend an interchange, or you can participate in the CDISC Fellows Program. And how many of you have heard about the Fellows Program? A few of you have, not everybody. Okay. Well, this is a relatively new program, and we're in the second year. The first year was a resounding success. We had 7 fellows from various organizations that participated, and the feedback we've gotten has been really good. But the idea is that they would actively participate in the development of CDISC standards on a near full-time basis for a fixed period of time, nominally a year. And I know that's a big ask, but, you know, I mean, you'll develop proficiency in standards development, use, and maintenance, and you'll acquire knowledge that can be leveraged internally by sponsoring companies. And we also ask that, you know, one of the other things is to provide ongoing part-time expertise as a reviewer or other participant at the conclusion of the year program. So for more information on that, you can click on that link. Here's a picture of the current class, the class of 2015 and 16. We have 14 people this year, so it went up, doubled.
So is the notion behind this that a company basically allocates, you know, one headcount for a year to this program, pays them, and then they get to sort of take back whatever experience they got?
That's right. That's right. Yeah. So yeah, it's it's an interesting experience. I think a totally different perspective, but I think it adds a lot of value, you know, in what they bring back when they come to their sponsoring companies. So yeah, so visit the website if you want more information about that. And that's all the slides I had. I hope I kept you awake. Any questions for me?
There must be some questions. Mickey, do we have questions from the online folks?
We don't have any questions.
Okay, I was going to say, we got to have some questions for this.
It was a great presentation.
How do you manage with public review comments, and what percentage get implemented into the published versions? Well, practically, we're using the CDISC portal to capture the comments. So you'd have to log into the portal and then, you know, open up the standard and then make comments using the portal tracker. And we're going to eventually, we're working on moving over to using the wiki to do that, which is much easier to actually enter your comments to that space. As far as the percentage, I don't really know off the top of my head. It depends very much on the comment. But we get everything from, you forgot a period at the end of this sentence, to, well, why haven't you fixed the issue with subqual? You know, I mean, it can vary a lot, the type of comments. But what we do is we're really transparent, and we respond to every comment that we receive, and we post that up on the CDISC website along with the posted TA standards. So you can go today and have a look and see, and look at the comments that were made and the responses to those. Does that help? Thank you. My pleasure. Yeah.
Rhonda, it was difficult for us to hear the question, so would you mind just repeating the question before you answer?
Okay.
Thank you.
I have a very stupid and fundamental question. Say my company wants to submit a breast cancer study, say today, programmers only have to prepare defined XML for SDTM add-in and plus ADRG. And I don't know how this TA can fit into this submission package thing. Or
Did you hear that one, the folks on the phone? He wants to know how the breast cancer standard affects the submission that you're just now putting into FDA.
Most specifically,
is that using to define an ADRG or
well,
report?
No, I would, first off, I would say that since you're already submitting, it's kind of like water under the bridge. There's nothing to be done for that particular instance. But going forward, there will be some changes because you have more standards to include, right, into the defined file and also into the SDTM submission. So you have new places to put things, so there will be some changes. So you'll have to do some sort of a gap analysis between what you have now and compare it to what's in the breast cancer TA user guide.
But the short answer is that the therapeutic area domains just become more domains in your SDTM database.
That's right.
More added data sets if there's added.
Yeah. Right.
Commentary.
That's right.
And so those would have to be included in your defined XML.
Okay.
So they're just part of the database.
So the frame of define is still the same.
Yeah.
So inside define, say define for SDTM to be different from today.
Mm-hmm. Well, I'm not an expert on define, so, but what you're describing sounds reasonable to me.
So this may not be a question to you, this may be more of a Sam Hume, but I'm really curious about CDISC share. And I know that that's built in RDF, and most of us are not experts in RDF. So I wonder if you could say just a little bit about the vision of the CDISC share team for how companies can make use of this information in implementing performance, and what they sort of see as the interface between the work that CDISC is doing and the work that companies would be doing for themselves.
It's definitely a Sam Hume question. I'll punt that to him. But, Becky wants to say something.
You can get more details from Sam, but let me just say it's not built in RDF. It is not. So share does is it's a metadata repository that helps you download your standards, and you can actually put them in various formats. You can get them in Excel or in ODM XML. RDF will be one of the options for downloading your standards. So if you don't want to use RDF, you don't have to. Does that help? Yes. Okay.
That was kind of a lot, so I don't know how much you get to that.
I just want to address the perception that share is built in RDF because it isn't. I can't tell you exactly the framework. The repository that's offered is one of what used to be called SOA and is now called Anita. It's a semantic manager, and it offers standards through eShare downloads in various formats. So you can get the CDISC standards in different formats such as Excel, ODM XML. RDF will be an option for downloading the standards in RDF. Some people have been asking for it in that format. So you can choose your format.
Hi there. So I've already used the TA for schizophrenia in its draft format. But just this morning, I'm helping to build a database for PAH, which is pulmonary arterial hypertension. And I saw that you are going to be working or are working on COPD. And then I also saw that you're going to be working on other TAs for new TAs. So I can imagine I could go to the COPD and get an idea of how I could build something for PAH. Is that kind of the concept?
Yeah, that's exactly the concept. And if you want, you can submit a proposal for the next stage TA to build on what asthma and COPD have already built on.
Great, thank you.
Sure.
Some of these therapeutic area-specific variables are captured in open CDISC validation. So is the long-term, I guess, strategy to make some of these therapeutic area-specific fields part of the standard SDTM package so that when you're validating it doesn't produce all these messages?
Yeah. There's changes that are happening right now to the validation piece, but we're definitely going to do that going forward. We just got a validation package from Japan that we're looking at as well. So it's definitely something that we're going to include going forward in the validation. It's really important. Thank you.
So one of the takeaways that I got from this is that if the FDA puts the QT therapeutic area user guide in the catalog soon, then within a couple of years, anybody who's doing a QT study, and everybody does because they're generally required for it, you have to have one in your submission. That if people aren't looking at that user guide and thinking about how they're going to implement it, by sometime, let's say, third quarter of next year or so, that they're going to be behind the 8 ball when it becomes an actual requirement, right?
Yeah, that's right. Yeah, it'll be a surprise. That's for sure.
So a year from now, when we ask the question again, who's implementing therapeutic area user guide, literally every hand should go up, right? So that's going to be quite a sea change. More? Okay.
All right.
Okay, next up is the Atom and Susan Chainey. So Susan has been associated with the Atom stuff for quite a long time. And I think it was probably about 10 years ago or something like that that she wrote I think it was the first white paper on a proper flow from source data to SDTM to Atom to analysis, and it's sort of become a classic of the genre since then. So let's get this show on the road. So Susan Chainey is our next speaker. As I said before, she's been associated with the Atom efforts for many years, and for a while was the leader of the Atom team, and is still involved, and is now become involved very deeply in the development of the Atom content for the therapeutic area user guides. And interestingly, until I started talking to Susan about this, I wasn't even aware that there was Atom content in therapeutic area user guides. I thought it was all SDTM. So it's been quite a learning experience for me just to put together this meeting. Susan is now an independent consultant, has sort of a lot of stuff in her background, which I'll let her sort of fill in for you. And her involvement in the therapeutic area user guides has been broad. It's been across a bunch of user guides, not just one or two. So Susan, why don't I turn it over to you, and let's just do a quick sound check and make sure that we're going to be okay here.
Oh, okay, well, thank you, John. And are we okay on that end?
Everybody here okay? Yeah, looks like we're okay. So I'm going to put my microphone here on mute, and then it's all for you.
Okay, just remember if there are questions, I guess you'll have to repeat them for me. I'm assuming if you put the microphone on mute, that means I can't hear anything.
Right. We will make sure that you hear questions one way or another.
Okay, good. All right. Well, thank you. And thank you for this opportunity. I was on a call earlier today with Rhonda, and she said, oh, well, I'll see you in a couple hours at the Bay Area CDISC meeting. And all of a sudden I got very sad because I'm not there. I'm on the other side of the country. I'm not able to fly over there for the afternoon, but certainly am glad to be here in a virtual sense. So I am happy to be able to talk about the ATOM content in the TA user guides and explain maybe a little bit about the history and what we're trying to do here. So just to clarify, my involvement has been over the last 18 months or so to help manage, if you will, the amount of content within the TA user guide. So I have not necessarily developed it all myself, but more, identified people who can help within that TA and who can develop the ATOM content in there. And of course, I work with them closely, but I just wanted to clarify it's not just me, but a team of people within each of these therapeutic area user guides. Okay, so how come I can't? There we go. Okay, so what I want to do today is first just give an overview of what we're trying to achieve within the ATOM content of the TAUGs. And then somewhat quickly, I'm going to go through all of the TAUGs that do have some ATOM content and on a fairly high level just kind of describe what content we have in there. And then next, kind of maybe go back a little bit and really discuss some specific content in selected TAUGs that I think people might be interested in. I'm assuming that many of you in the audience are statisticians and programmers and maybe would be interested in some of the details about the ATOM content of particular TAUGs. And then lastly, just want to close up with talking about some challenges we've encountered and considerations moving forward. Okay, so Rhonda, I just always love her presentations about this entire effort. You've had a good impression of how complicated it is and encompassing. So certainly end-to-end standards does include ATOM or the analysis of that clinical trial data, but I think we all are aware that, harmonizing ATOM examples and metadata and structures and such is a little harder than perhaps doing that for a CRF page or SDTM domain because, ATOM is designed to support a specified analysis specified for a given protocol, which is designed for a given patient population, et cetera, et cetera. So it's a harder thing to develop, but I think we all would agree that having some amount of ATOM content in the TAUGs is certainly better than none. And I'm fond of the expression from one of our past presidents of let's just do what we can with what we have and where we are. So that, at least for the past 18 months, has been some of my internal motto of what we can do. So just like with the rest of the TAUGs, we want to use the latest standards. And for the most part, what we have in the TAUGs is either version 1.0 or some of the 1.1 content. We use define 2.0 conventions wherever we happen to show a metadata, especially parameter value level metadata. And certainly the main goal here is to illustrate the use of an ADAM standard, and wherever we could, we tried to keep in mind, well, where are difficulties in implementing ADAM? Are there gaps in terms of variables or modeling issues that maybe we could move forward into the ADAM model, just like they have done for the SDTM domains within the TAUGs to identify, well, okay, well, you know, we need a new domain. What do we need new in ADAM to address some of the therapeutic area specific analyses? So our basic format, it's just really a kind of an introduction to the analysis that would be typical for that TA, describe important subject characteristics that you would see in ADSL, and then from there develop analysis data examples. And for the most part, we focused on primary efficacy endpoints. And then we have a varying degree of metadata that's presented. We always try to have the data set level metadata, variable level, including parameter value level when we're using BDS, and then table shells and analysis results metadata. But there have been varying degrees of the amount of this metadata, and I'll touch upon that in a subsequent slide. Now, all of these TAUGs, you know, we're developing them, you know, without any study specifics that normally would be present, as I've mentioned. And like I mentioned before, for ADAM, that is particularly problematic because we don't really know what the analysis would be, and maybe what the derivation rules are, etc. So that puts us a little bit in a bind. And one thing specifically is we don't have what's called an estimand, and that's a statistical word for the efficacy endpoint. So let's quickly just describe that. You know, think about dyslipidemia. The primary endpoint, you know, as in a clinical sense, are laboratory measures of cholesterol. Okay, that's your endpoint. But then when you go to analyze that data, what is it that you're going to compare between treatment groups? Is it the change from baseline, a percent change? Is it a responder analysis? That's what we call an estimand. So, you know, we do have statisticians on the TA user group teams, and they can often provide, you know, what they have seen in their experience are common ways to analyze the primary endpoint. But, you know, there's a lot of variability there between sponsors for a given TA about how they analyze a particular clinical endpoint. So we've done the best as we can to develop models that could be universally applicable as best as we can. But we do have that disclaimer in the TAUGs that the ADAM examples are examples. You know, we're not saying that this is the way you have to derive a certain variable. We're not saying that, you know, this is the patient population that you're going to have to use, et cetera, or the, you know, the statistical proc and SAS with the certain options on the model statement. These are just, you know, examples, and I think it's critical for the agency to, feel comfortable that people are not thinking, oh, this is the way I have to always analyze my data for this particular TA, because that's not really the message that we want to convey with these ADAM examples. Okay, so let's look at what we've done so far of the TAs that are either published or soon to be published. Now, first, these are the ones that in version 1 had no ADAM content. And, you know, with Rhonda's talk, I'm sure you have an appreciation of what a gargantuan task it was to get this entire effort organized and off the ground. So it comes as no surprise that we couldn't boil the ocean all at once, and so some of these first tags, had no atom content, and we'll deal with that, in version 2 as we update these. But then the ones that do have atom content, now the diabetes atom supplement, we've actually just finished addressing everything, all comments today, and that will be going to the SRC to be published. I don't see any reason that won't be published before the end of the year. Now this one was kind of special. It was conducted as a separate pilot project from the parent tab, and so it has the most content. In fact, it's I think it's 98 pages. Well, maybe not that long. It's many pages long. Maybe it's about 38. So that's pretty long. We have a lot of extensive content in there, and I am going to go through this a little bit later. From there, hepatitis C also published. We became involved in that late in the process. So the analysis section here really is just textual. We don't have any actual atom examples, but we do discuss analysis issues and how you would approach the development of analysis data using atom standards, and we touched a little bit upon some of the guidance documents and what a reviewer might like. So it's a textual document that hopefully can just give somebody who's working in this area some things to think about when they're developing their analysis data. Dyslipidemia is, we have ADSL, we have an efficacy BDS data set, and also present a table shell with some analysis results metadata. QT studies, now this one was done quite a while ago, has a ECG and BDS, and then BDS to support the analysis of QT corrections, which if you've ever worked in that area, is really complicated. Now this one, because it was developed well over a year ago, the metadata for this is shown using Define 1.0 conventions. Not that there's anything wrong with that. I'm just mentioning that it used the standards that were available at that time. Schizophrenia really just has literally 3 short paragraphs about analysis issues. So, it has analysis content in there, but no real atom content. Virology 2.0 was a little bit of a different kind of tag in that it primarily is related to some of the pharmacogenomic issues related to the analysis of virology, and we do have a short section in there talking about some of the subject characteristics and illustrate an other analysis data set that was really presented as a way to support review. COPD, Rhonda mentioned, that will be published very soon. We're almost done with all of those comments, and we have ADSL, and we have using the occurrence data structure for exacerbations, which is the primary endpoint for COPD. And then we also show another example of how we can take 4 BDS data sets to create a new BDS data set and do some transpositions. I'm going to show an example about that later. Next is diabetes kidney disease. This will be going out for public comment in the near future. And here, time to event of time to end-stage renal disease is a typical primary endpoint. So we show how that can be approached by using 2 intermediate BDS data sets to support a final TTE data set. Breast cancer, as Rhonda mentioned, really received a huge amount of interest, and the team took the tactic of, for this one, having a fairly lengthy text section about just general analysis issues in cancer in general, a lot about censoring rules and dates and things to be aware of. And then from there we have an ADSL, somewhat abbreviated, and then a depiction of an intermediate EDS data set that collates all of the event information on its way to develop then the final time to event data set. And I'm going to talk about this in the next section about it introduced a new atom concept called PAR-QUAL. We're finishing up rheumatoid arthritis to get that ready for internal review. This was a pretty fun project to work on because in a way it's a very complicated primary analysis that is a composite measure that pulls from up to 6 different analysis data sets. So the flow and the relationships between those data sets is something we wanted to illustrate in that TAUG. We also, for the first time, are we developed and are proposing controlled terminology for param and param code related to some of these published questionnaires. Again, that's a new thing and has never been done before for ATOM. So that was just a very quick overview. If you look at all of those TAUGs that are out there, you will see that there is some variability in content. We did start with early on having table shells with results metadata for everything, but we ended up not doing that for every single TAUG. After a while, it became kind of variations on the theme, if you will, and wasn't necessarily providing any new content. We did try to keep that outline the same, but for some of the TAUGs, some of those sections are more lengthy than others. We tried to pretend, if you will, when we showed variable level metadata that we were giving a really good example of a source derivation. But sometimes that wasn't possible because, like I said, we didn't have a derivation rule. We didn't have a real definition of how something should be derived or created. So some of our source derivations are more like notes. This is what this variable would be for, and other times they are more like defined compliant type illustration of metadata. So now let's go to the good stuff and just go back to some of those TAUGs and look at the specific content of them. So the first one I want to spend more time with than the others is this diabetes atom supplement, just because it is so much more extensive than the other ones. So one thing we did in here is we have developed some stratification variables that we're proposing to be added to the ATOM implementation guide 1.2 that's in development right now. So we're about ready to publish 1.1, and we're already working on 1.2, and we're hoping that these stratification variables would become part of ADSL and therefore be used by industry as standard variables. So this was somewhat of a gap, if you will. There were no variables to indicate the values used for different stratum, nor the description of those stratum, nor the values that a subject was randomized under. And then we have this difficult situation that sometimes the value that a subject was randomized under is not what they should have been randomized under, and they get verified. You have then a verified value, and If that's a little confusing, well, I'm hoping that if you look at the TAUG, it will be a little more clear. And so what we have in there is what you might typically see within an implementation guide, where we have the variable name, label, et cetera, and CDISC notes to describe all of these variables. I'm not expecting you to read this. I just really wanted to let you know that if you look in that in that supplement, you'll see a full description of all of these variables. Again, I don't necessarily want to go through this in detail, but we have a variable for the strata, and then which can be multiple individual stratums, and then we parse that out into individual strata names, description, and then the values. So this is important. Well, it's important, of course, to know what strata somebody was randomized under, but also if there are errors with respect to what they were randomized under versus what they should have been, that often drives the need for sensitivity analyses to do the analyses under as verified strata. So that's part of the whole reasoning we created these variables, was to illustrate that situation. Okay, next in the supplement, we have a section for the analysis of hypoglycemic events. Again, this is a common endpoint. Not only it's a usual safety endpoint, but sometimes it can also be used as an efficacy endpoint. And there is a relatively standard definition used in the industry to develop or to identify, was this a hyperglycemic event? So that we had that working for us, that we were able to really build a data set where you could show how something was identified as a hypoglycemic event, because that it doesn't necessarily just, it's not like a tick box that you get from SDTM. The information comes from a number of different places. Clinical event, the time since the last meal, ML is a new domain in the diabetes TAUG, an FA, and then certainly the glucose levels in LB. So you have to assemble all of that different variables from multiple places in SDTM into an occurrence data structure. And once you have all of those disparate variables, then you can define things like severity, or was it a nocturnal event. For some analyses, the relationship of that event relative to the last meal is important. So we can see how this occurrence data set, the classic thinking of occurrence data set is, oh, it's for adverse events or medical history or ConMed, which that is all true, but this structure can also be very useful for these kind of situations where you collate occurrence type variables that are spread across multiple SDTM domains and put them back together to basically identify an event. So from that occurrence data structure, we can produce an incidence table that looks, very much like an AE table, where we have counts and percentages. And in this example, we did it by severity. For HbA1c, I call this the classic BDS. Really, nothing earth-shaking here that you would be new to you. We're illustrating the use of a crit flag to identify records that satisfy a fairly often used criteria. Was HbA1c less than 7%? And here's our target shell, which uses a repeated measure model, and then the results metadata that goes with that. Again, this is all just an illustration of the application of the full end-to-end atom model, not meant to be, this is how you would always analyze your HbA1c data. sorry, I thought I had one more slide in here. The fourth section of the supplement has to do with analysis of measures of glucose. Okay, no surprise there that glucose is commonly used to develop primary endpoint analyses. So we have one for self-monitoring blood glucose measures and relative to some meal data. So sorry, I'm not showing examples of those, but in general, they're BDS type models, and we have some graphs and table shelves that we've illustrated with that. So this supplement is very extensive, and this project had the luxury, if you will, of being a separate work stream, separate from the rest of the TAU team. So in a sense, you know, we took as long as we needed to develop this extensive content that we normally wouldn't have in the timeline associated with a given TAUG. So this was a good project, and I think the document that will be published here momentarily is going to be a great resource for ADAM implementers, but it probably is not something that's intended to be repeated for the other TAUGs. What we really want to do, like we mentioned, is bring at least some of that ADAM content into the parent TAUG where we have the opportunity to. So breast cancer, I mentioned that there was a lot of interest in this. So the design that was used here is an option of using an intermediate data set that is a BDS structure, but what this intermediate data set does was just basically collate all of the sources of information that are candidates, if you will, for determining either time to event or time to censoring. So you have dates for every possible event of interest, every possible censoring event. And so it's all kind of there in one place, and then you basically just pull the, you know, the first event to create a final TTE data set. Now, there were some differences of opinion on the ADAM subteam as to the need for this AD event, as it was called. This approach does provide some nice traceability, but people felt like there were other approaches that could be equally valid to achieve traceability. So, I mean, this is just an example of how, you know, this is a really nice example. If it works for you and it's something that you like, then that's certainly an option, but it's not necessarily meant to be implied that everybody needs to create an AD event data set. Now, we have a number of other oncology TAUGs coming up with prostate cancer and bone and colorectal cancer, so we'll have other opportunities to either repeat this and see how it works for those, or illustrate, you know, a different approach. All right, I mentioned that this is the TAUG and the only place that we have presented something that is not in the ADAM implementation guide, and that's this new variable called PARQUAL, which is parameter qualifier. And I'm sure many of you ears are perked up because, you know, we make a big deal in the ADAM documents that param can have no qualifiers. The text of param has to be fully descriptive of what's an ABAL. But this example is one that this PARQUAL would be a special purpose variable and would be used in a very limited situations. But one common situation is what happens a lot in cancer, as well as maybe other TAs, where you have different evaluators or adjudicators who are looking at the exact same data exact radiographs. They're doing things exactly the same, but they're coming up with different assessments. So in some sense, param and param code and AVAL still all mean the same thing. It's just the qualifier is who's doing the assessment. So here's a very baby example where our parameter is an assessment at a given date, and then the result of that, stable disease or progressive disease. And so PAR-qual is used to indicate, well, this assessment was done by the investigator, whereas this assessment was done by a central reader. And so we can see here is an example where, the investigator looking at the radiograph said, oh, stable disease, but the central reader said, no, they've got progressive disease. So, having both of these in the data set together with this qualifier can help you, compare and contrast or choose, which of those records gets taken for your time to event. So this is a new variable. It's not published. It's being considered by the ATOM team. When it would be, if and when it would be in a new IG, I couldn't tell you if it's going to be in the next 1.2 version or not. It is something we're working on. But anyway, it should be considered that it's not final. It's certainly good to know about and, begin to become familiar with it if it's something that you feel that might be useful to you in the future. Next, the COPD, also almost to be published. This one was particularly challenging because exacerbations, of course, are the primary endpoint, but there is no universal sponsor definition for how you determine that. So, it's a common event that people have who have COPD. They have an exacerbation, but is it an exacerbation or is it just a regular AE? And in this project, there was lots of back and forth with clinical and SDTM folks about what to collect and where to put it, et cetera. And so what we kind of had to do is be somewhat, I don't want to say vague, but without an actual definition and derivation, all we could really do is develop somewhat of a high-level occurrence data structure that, similar to the situation in diabetes before, it really collates from a whole bunch of different SDTM domains and creates an occurrence data structure from which then we are able to identify whether something was an exacerbation. But we kind of were shooting in the dark, if you will, to some extent, because we had to just say, well, pretend that you wanted the definition to be like this, and if so, then this is how you could model it. And then the other example we have in COPD, this is not a primary endpoint and probably isn't even all that important for COPD, but because we kind of got squished, if you will, with respect to the exacerbations, we felt like, well, we needed to have more content in there, and we took that opportunity basically to illustrate how we have these, there's this measure called the BODE index. It's a composite score in COPD, and basically there's four different measures that go into this BODE index. And so those 4 measures would be in 4 separate BDS data sets, and then this final BODE data set pulls from those 4 and creates the composite index. So AVAL is the value of that composite index. But what we did is basically showed how we have these 4 supportive columns. The variable names are the param codes from the 4 parent data sets. So it just gave us an opportunity to demonstrate a good application of traceability and how you can have related analysis data sets that provide that level of support. Lastly, the rheumatoid arthritis, actually, like I mentioned, has been one of my favorites just because it's a very interesting disease. The primary endpoint is based on a % improvement of data from 6 different places, and there's different measures and issues about all of these. So, as well as there's a lot of important subject level variables and covariates. So for this TAUG, like I mentioned, the flow, we're spending a lot of time developing documentation basically to say, like, these 2 data sets in green are intermediate data sets. You wouldn't necessarily need them if you weren't, unless you're doing some particular issues with imputation, but so these are joint counts, and in a simple situation, you could go directly from SDTM right into this joint count summary data set. You wouldn't need to have this because this is pretty much just SDTM. And same with this. This is a questionnaire, individual questionnaire. You might not really need this intermediate data set. You could go right to the ATOM data set that has the domain scores and the total scores. And then we have a couple other data sets, lab, as well as some data sets to support visual analog scale results. So once you have assembled all these 4, then you pull from all of those to develop this composite score at different levels. It's called ACR 20 or 50 or 70 or whatever. There's different cut points you can use. One other particular issue with this is that many of these values, well, these are all fairly highly derived within here, and certainly here. You want to know at a subject level the baseline values of these. Well, let me go to the next slide. Wait a minute, sorry, I'm getting ahead of myself. Hold that thought. That thought about the consolidated subject level data. Let me just finish off here with the TAUG. So I also mentioned that this was the first time that we developed controlled terminology for param code for the things that are closely associated with questionnaires. So we are proposing CT for the derived subscores and total scores that would come in test code. So this was the first time we've done that, really, in any TAUG, much less for ATOM. As I'm sure you're well aware, ATOM has precious little controlled terminology. All right, now is where I kind of wanted to talk about some of the challenges and considerations as we've gone through these TAUGs with a number of different examples and different therapeutic areas. We've had some challenges along the way, and one of these, like with COPD, we kind of, ATOM gets, like in the real world, the analysis comes last, so you kind of have to get, your CDISC and your SDTM settled before you can do the ATOM. So with COPD, we kind of ran out of time, if you will, because there was so much churn about how to represent data about exacerbations. So, but I feel it's always important to look on the positive side of things. So even though what we have in COPD is abbreviated and there's just some amount of hand waving going on, it's still useful. If you're familiar with that TA, you probably should be able to pick that up and kind of expand it for your needs. Another kind of challenge, or just something to consider for the future, it has to do with adjudication data. In many ways, I think of adjudication data as being TA agnostic. It happens a lot for a lot of different TAs. but there isn't a real standard way that sponsors manage these data within their shop. Sometimes it goes directly into the EDC system and is easy to flow into SDTM. Other times, sponsors collect this, outside of their EDC system, and it usually ends up being managed in ADAM. And there's lots of pros and cons with each way. We really have wanted to be able to show some ADAM examples with adjudicated data, but we really just haven't had that opportunity because right now the couple of tags that have examples of adjudicated data is fairly simple, and it just ends up in SDTM, and it would be hard for us with that approach to really develop a realistic ADAM example from there. But I'm hoping that we can keep exploring this, and if nothing else, just have some more discussions or documentation about some of these pros and cons and what we should do as an industry in terms of handling adjudicated data. So yeah, this is back to the RA issue, where we have these very highly derived subject level baseline values. Now, you all are probably well aware there's a lot of process issues with putting them in ADSL from the very beginning, because they're so derived. It's a circular kind of problem. So the consideration is, can there be a second, one record per subject data set that's created at the end? And there's differences of opinion within the ADAM world. Well, can you have what amounts to be a second ADSL at the end, or what? Does it have to be a BDS or some other kind of structure? So this is not a new issue, but hopefully this will continue to spur the ADAM team to document a solution or a position about this, because it comes up, quite honestly, all the time. Lastly, we all know ADAM is flexible, and there's no one right way to do the same thing. There's some better ways, but often there's multiple reasonable right ways to do the same thing. And then that's like the situation in the breast cancer TAG. It's a great example. Is it the only way to do it? Probably not. So one of the challenge here is where is that sweet spot in communicating or developing an ADAM example in a TAG that, hey, everybody, wouldn't it be nice if everybody did it this way, versus this is one way we approached it. So not only in the design of the data sets, but also even with the variable names. Back to Rhonda's slides, are the variable names that we have in there for the subject level variables, are those normative or non-normative? If they're normative, does it matter that my metadata might differ from your metadata because it's the same concept, but I've used a completely different derivation method? So these are things I can't answer. I know that we're kind of the problem child of share, because we have variables, standard variables with standard variable labels, but the metadata differs between studies and sponsors. So I think that's viewed as an obstacle within share. So this is something, I can't really answer. My feeling is if that variable name in the TAG works for you, then why wouldn't you go ahead and use it? But again, nobody's saying that they are normative, and I guess it would have to be actually brought into the ADAM IG for it to be considered to be a normative variable name. The other thing we've done, I don't know how many of them now, 8 or 10 of them. So the question we're beginning to, contemplate, well, how many good examples of ATOM implementation do we need? I think we've done a great job in presenting some good high-level examples that are applicable to the TA, but without having, exact estimates that I mentioned, exact derivations, any kind of full analysis, full understanding of analysis issues. Our examples always will be approximations. We won't ever really be able to fully show here is an occurrence data to support this precise definition, because we don't have that precise definition. So we're thinking, well, would it help to have maybe more enhanced discussion on important analysis issues, maybe somewhat what they've done like with breast cancer, where there's more documentation about, hey, here are important things to think about in this TA. Missing data is a big problem, so here are ways to, impute this or what have you. And again, this is an open question, but, would that enhanced discussion about the analysis be more helpful rather than abbreviated ATOM examples? So in closing, I like to think of challenges really as being opportunities in disguise, because, if this was easy, then, we all would have been done a long time ago with all of this. So you've got to keep trying. Like Rhonda said, we have to try somewhere and just keep building on our experiences and finding, what's best for the industry as well as the regulatory agencies. So I would like to second Rhonda's suggestion to please get involved, and at the very least pay attention to when these tags come out for public review, and review the content, provide your feedback on the ATOM examples as well as the rest of it, and we'd love to hear how the examples are working for you. So with that, that's my last slide. So thank you so much. And John, remember, I can't hear you.
Right, yeah, so I just took off the mute, and you just missed a lot of applause.
Okay. I have one question from our online attendees.
Okay.
Okay.
The question comes from Sandra Minjo, and the question is regarding the par-qual variable that you discussed. Can Susan clarify that this provisional variable does not contain a Y and is intended for exactly one qualifier? In other words, it doesn't open the door to creating a whole suite of qualifiers for param.
Yeah, I kind of missed that. Missed part of what you said. It does not contain a lie? Is that what you said?
A lie. So, for example, a character that would allow there to be perhaps a 1, a 2, or a 3, so you could create multiple variables.
Oh, a Y. No, I think, so to answer the question, I would hope not. I think that's why the ATOM team is having a lot of trepidation, if you will, with introducing this concept, because we know that some of the, the virtue of the basic data structure is that parameters don't have qualifiers, and if you start having qualifiers, you end up kind of destroying some of the virtue of the BDS structure. So this is something that will be discussed, over the next few months with the ATOM team. We have rules. The sub-team is working on these. They have rules about when par-qual can be used and when it cannot be used. And I think if this variable is ratified by the ADAM team, there's going to be a lot of restrictions on it, and I would suspect that there would be no Y on there. I can't say never, but I can't imagine that we would go down that route.
We have a question from the audience now.
My question is regarding Part again. What is it that you need that I cannot gain the same thing by using param code? I could define a unique param code and it gives me the same thing as Part, right? So why would I have Part?
Did you catch that, Sue?
None of it, really. So can you interpret that for me?
I think.
Can I repeat? So my question is why Part 1 when I can achieve the same thing using param and param code?
Is the question, sorry, about ParQual again?
Yeah, right. So the question is, why have a ParQual when you can make the distinction using param and param code?
Yes. No, I completely agree with you and understand your point, and I think that's what is being discussed. The feeling is that for situations like I described with the different readers, that the concept of the parameter is the same. It's an assessment, or it's, and the fact that it's viewed by one person versus another doesn't change that concept, and it doesn't change the meaning of eval. And I think people are thinking in terms of controlled terminology for those concepts where it's applicable to that it would be useful. There's another situation that I probably am not going to be able to describe just without some slides or text around it, but having to do with PK analysis where you have different metabolites of the same drug, and so you have AUC for this metabolite, AUC for this metabolite, etc. And if you tried to make those all within param and param code, you know, you have no hope at all of having standard param and param code pairs. But if you use the ParQual for the metabolite part, that can actually make your data set a little more manageable and meaningful. However, having said that, you know, you have to know that that qualifier exists so that you can select the given Cmax or AUC depending on the metabolite you're interested in. So I really appreciate the comments about ParQual, and I would encourage everybody, you know, to offer their input and suggestions to the full ADAM team as this is discussed over the coming months.
Okay, we have another question in the audience.
I have a question about the therapeutic area guide for diabetes. You said that was one that was extensively worked on. If we're working on an area where there is no user guide, is there information in the one about diabetes that is general enough that we could look at it, or is the better way to try to find a therapeutic area that most closely relates to what you're working on? Do you understand my question?
Yeah, well, I was able to hear that question, and thank you for that question, because that's a point that perhaps I didn't make clear enough, in that I feel that many of the examples we have in each of the therapeutic area guides are really nice examples of the application of the ADAM model to a given situation. And so in many cases, what we've demonstrated in different TAUGs could be applicable to other TAs as well. so just by extension, an occurrence data set that assembles data across multiple SDTMs to define some occurrence of something, you could look at what we did in the COPD or in the hypoglycemia diabetes, to get, an example of what we've done. So yes, I think that's why I was saying at my last slide about considerations. Like, we've developed a lot of really nice examples of ADAM implementation that all fit under the current ADAM IG, with the exception of Parkwall. And really, could those be viewed, collectively as ADAM examples for the industry just in general, irrespective of the TA? So to answer your question, that was a long-winded answer. Yes, I think you could definitely use a given TA example for, to get ideas or direction for a different TA.
I suppose the challenge is trying to sift through all of those tags and figure out what is there that might be applicable for your own study. Okay, well, thank you.
Yes, that's true.
More questions in here? Oh, I have a question for you. You talked about ADSL being you have rules and examples for ADSL in there. The question I had was, how would a user reading one of these therapeutic area guides integrate the information from that guide with their actual ADSL for the entire study analysis? Are those examples intended to be integrated into a single ADSL or a second ADSL, in addition to the one for the rest of the study? Or, you actually touched on that a little bit, I think, in some of the later slides.
Well, what I was saying, I might be misunderstanding your question. The issue with the rheumatoid arthritis situation was, how do you assemble all these complex derived subject level variables that come from your efficacy analysis? So you kind of have to do your efficacy data sets in order to get these variables. So there's process issues with trying to put those into the very first, the ADSL as the first data set. So that issue is kind of that separate issue of how do you, how do you manage that? Yeah.
Issue of the circularity of the that's right.
Right, and the real issue is, and this is where there's differences of opinion, is can you have another one record per subject data set that is not called ADSL, that collates a bunch of stuff from all sorts of different places, maybe like as the last data set you create, where it just assembles things together. That's really what I think the ADAM team has to, clarify. But as far as the ADSL examples and the tags, for the most part, we try to itemize, here are the important subject characteristics, baseline characteristics or medical history or, treatment naivete that might be important for this given TA. But of course, it really is going to depend on your given protocol and your analyses. So what we have in ADSL are, examples of using, primarily the ADAM variable name fragment to create, a grouping variable or a baseline variable or some flag variable. And that's why I was saying my last slide, should we think of those variable names as normative or non-normative? Yeah.
I think we have another question from the audience.
Yeah, so I think this is related to what John is talking about. So I appreciate your comment that not to include highly derived variables in your ADSL. And so my question is, if you do include a variable, for example, last date in study, or even more complicated, last known alive date in your ADSL, what is the risk in having the user, for example, from the regulatory agency, misuse this variable that you have included in your ADSL?
I might not be fully understanding what's being misused. So let's take the last known alive date. Now that's an example of something I don't think of. It seems like that should be able to be traced fairly, well, I won't say easily, but it seems like that should be traced to SDTM. There's somewhere in SDTM is the last known alive date. I don't think of that as highly derived.
No, it is, because it can come from several data domains. And so I think what we're struggling with in our organization is that it is mainly an efficacy variable, but it's good to have it in the ADSL because you have this one data set that has data points or data elements per subject, and it's just that we don't know how the reader or how the end user will use it outside of the company, and so we're just struggling on how to define these variables, or maybe we shouldn't even be including it in the ADSL.
No, yeah, I understand what you're saying now better, and I appreciate that. And in fact, I didn't talk any about the virology therapeutic area user guide, but we did actually broach that very issue in there. It wasn't about last known alive date, but it was efficacy responder flag. So reviewers often want to know, along with all the other baseline characteristics and subject level characteristics, at the end of the day, was that person a efficacy responder or not? Well, you kind of have to do your complete efficacy analysis, even maybe modeling, in order to know that. So that's a hard thing to put in ADSL at the very beginning. But so you're right, we don't have a consistent or a best practice, if you will, for how that happens, and I think it needs to, that discussion does need to happen within the ATOM team development, because I think we're seeing more and more of those concepts that reviewers want to have, along with all the other baseline characteristics that really are derived at the end of the day.
Susan, I think we're going to have to cut questions short because we're running short for the whole thing. Mickey, are there any other questions from the online folks? I'm going to take that as a no.
No, there aren't any.
Okay, thanks. Okay, so thank you, Susan. Let's have another round. So we have roughly half an hour left for the last two presentations. The next presentation is Anita Umesh. I hope I pronounced that right. And like I said, Tricia from Clinovo hooked me up with Anita, and she was actually literally the first person that I had ever talked to who had attempted to implement one of these guides, and she was actually on the committee that created the breast cancer therapeutic area user guide, which is right now in the public comment period. Public comment period ends today, right? And is about to be published pretty soon. And so she's been trying to implement it at Illumina and has some examples from life about what kind of challenges that involves. And then after Anita, we'll hear from Jonathan Chainey, who can fill you in on his new role at CDISC, but he's also head of data standards at Genentech Roche, and is local now. He just actually moved here pretty recently, and he's going to be talking about governance. You know, how the new therapeutic area standards, what the challenges are of sort of folding them into a governance process. And I think this is going to be a really important topic. So stick around for it, please.
Okay, so I'll be talking to you today about the breast cancer therapeutic area user guide. As John mentioned, I'll be going through the user guide, so hopefully after this, if there are any public comments, please go and put it on the CDISC portal, because comments are due today. Okay.
Excuse me, John, please be closer to the microphone.
Is that better?
Maybe even a little bit closer.
Is that better? Okay. A little bit. Okay. Now? Yeah. Okay. Okay, so this looks like a long list of agendas, but actually I only have a couple slides per agenda because I'll be going through these fairly briefly. So as was mentioned, this BRCA-TALG is the first therapeutic area user guide in the field of oncology. So I just want to quickly point out some themes that run across oncology, and then go into one slide of incidence of breast cancer, and then go into details of the therapeutic area user guide. And at the end, I'll talk about our specific use case at Illumina, and present you with a couple of very technical challenges that we've been facing. And I'm guessing that if we're facing this, that we're not the only ones. And finally, we'll conclude with the wish list specifically for SDTM examples, because that's where I'm primarily involved. So broadly, oncology can be categorized into solid tumors and hematologic malignancies. These are those would include blood cancers. Breast cancer falls under the first category. And main things within diagnosis of cancers is that might be different from other therapeutic areas would include things like staging, grading of the tumor, histology of the tumor. Are there any molecular markers within the solid tumor or blood? There's a concept of, in addition to an anatomic location, there's a concept of a relative location. Is the malignancy local, regional, or distant? In terms of treatment, there are a couple of concepts that might be a little bit more unique to oncology, such as the treatment intent, whether it's a curative or for palliation. The setting, is it neoadjuvant, adjuvant, or metastatic treatment? And the endpoints that I believe Susan talked about in the ADAM presentation earlier of complete response, partial response, stable disease versus overall survival, disease-free survival, progression-free survival that might be more derived. So just to give you a quick overview of breast cancer, it's a solid tumor that arises in epithelial cells of the breast, usually within the duct or the lobes. One important consideration in looking at breast cancer is looking at the axillary lymph nodes, which are the green dots you see in the second image. In the U.S., it constitutes 29% of newly diagnosed cancers.
and in women, and 15% of cancer deaths in women. 5-year survival rate, this was taken from SEER from 2005 to 2011, is about 89.4%, but as can be seen in the bar graph, it depends on what the state of the cancer was when it was first diagnosed. As you can see, the 5-year survival rate drops to 25.9% if the disease is diagnosed at metastasis. Okay, so I joined the breast cancer talk team about 1.5 years ago, and the primary objective, as I understood it, of the team was to provide not necessarily guidance, but examples on how one can collect systematically data that is relevant to breast cancer. And I mean, this also includes parts of oncology. How to tabulate the collected data with minimum loss of information. And in order to also, 3 is to facilitate downstream analysis from the tabulated data. That's SDTM. So how's this achieved? Rhonda touched on this in her talk, but this is achieved by creating concept maps. First by gathering the concepts that are important in a therapeutic area and creating these concept maps. I'll be showing you a few of them that's in the document. And a second component is the providing example CRFs of how one can organize a case report form so that such relevant data can be collected. And tabulating what's been collected from those example case report forms into example SDTM tables. And as Susan talked earlier, this therapeutic area user guide contains the ADAM component too, and examples of analysis data sets. So this user guide focuses mainly on data. It focuses on describing data that is common in many breast cancer studies, and it comes from the information was gathered from, so there are about 50 people on the breast cancer team, about maybe 25% of them. We have 2 weekly calls, so 2 hours a week, and about maybe 25 to 30 people participate in those calls. And we have different subject matter experts and a lot of people from different organizations who've contributed case report forms, for example, and other concepts that their industry covers and collects and things of their organization's interest. So this document describes such data that is commonly collected and is deemed important from these different organizations, and describes it so that it's easy for data managers, statisticians, programmers to understand and apply these standards. The document also describes biomedical concepts that have been standardized. I'll go through a few of them that have newly been standardized within this therapeutic area user guide that's new to CDISC also. And the objective of this is, of course, to try and use consistent terminology so that data from disparate sources can be, and different data sets can be aggregated and compared together. So the bottom, so this diagram shows one of the concept maps in the talk, and it shows you that in breast cancer, the treatment can have different intent, whether it's curative or palliative, and depending on the intent, it could be used in different settings, whether it's neoadjuvant, so neoadjuvant is given before primary treatment, and for solid tumors, the primary treatment is surgery, usually. Whether it's used in an adjuvant drug treatment setting where the treatment is given alongside a surgery, or an advanced setting where the disease has metastasized. And depending on this, you'll have different endpoints. For example, in the neoadjuvant setting where you might give radiation prior to surgery, you'll look to see if the radiation has shrunken the tumor, and this would be part of a measurement called pathologic complete response. The box to the very left on the bottom level. So this would be this is something that would be collected specifically in a neoadjuvant treatment setting. Okay, so there are a couple things that are different in the breast cancer TOG. So the one thing is this this document represents the subquals as a non-standard variable. So there's no subqual tables, but instead they are shown. Does this work? Okay, great. So so this is what would have been a subqual, right? And so I guess the non-standard variables are represented in line with the standard domain, but with a black bar for the column headers and separated by a space.
So this is the approach that is going to be presented in IG 3.2?
3.3, yeah, so this was proposed in the IG version 3.3 when it went out for public review last year. And so this team has chosen to represent the data in this way. And so there's one more thing. Oh, so I forgot to mention earlier that, so this is an example table of an actual non-standard variable. And so this non-standard variable table, is accompanied by a non-standard variable metadata table that explains the variable, that lists of variable column headers, variable names, the labels, the type, and this is much like a subqual table. But one thing that's new is that for some of the non-standard variables, the team has come up with control terminology, which I think might be new also. So two examples are for treatment intent. There is controlled terminology including curative and palliative, treatment setting, neoadjuvant, adjuvant, metastatic. Those are, I believe those are the only controlled terms for these non-standard variables right now. And so you'll see a code list here also in the metadata table. So I'm going to go through and show you some screenshots from the specific sections of the TOG, and these are the sections that are covered after the introduction, basically. So we have diagnosis, staging, pathology, prior treatments, risk factors, treatments, and then the tumor identification, assessment, disease response, disease recurrence, and then known issues. Okay. So this is an example of one of the concept maps that's given for diagnosis. As you can see, there are many different ways. This diagram is quite busy, but mainly diagnosis is performed either clinically or through a tissue specimen. The clinical examination can be a result of imaging, examination, or self-assessment. And once a biopsy is collected, it would be processed downstream by a pathologist for pathological assessment. And of course, a tissue specimen can be given for genomic analysis too, like arrays. And this would constitute the initial diagnosis. So this this document for diagnosis actually goes through quite in depth and explains these components. For disease staging, this is something that the team tried to model quite a bit, but the modeling has been deferred to a later version for numerous reasons. One of the reasons is for disease tumor staging, for those people who are in oncology, of course, the TNM staging from the American Joint Committee on Cancer is used, and then to assess an overall stage. T stands for tumor size and is the presence of metastases in regional lymph nodes. M is metastasis beyond the breast, so distant metastases. And the higher these numbers, the more severe the condition. So I guess this is a copyrighted item from AJCC, and the team did not get permission to use this currently. So I think there are people on the team who are working on this to get copyright so that we can model this and provide examples, because this is a very critical component of oncology studies. Okay, so the pathology section contains a very busy concept map again. It basically goes into, if you remove the cancerous tissue, it describes how the tissue is sampled, what kind of assessments are made for pathology, histology, or gross, assessment of margins, or gross measurements. So these are the tumor dimensions of the TMM staging that I alluded to earlier. And from that, there are different types of, from the histologic examination, there are different types of parameters that can be measured, like what is the histology, what is the tumor grade, is it poorly differentiated, well differentiated, all of these things that can make an impact on the prognosis of the disease. Let's see. This section also has many tables describing different concepts. I'm not going to go through all this, but these are all tables in the implementation guide that describe things like what is estrogen receptor, what is progesterone receptor. These are hormone receptors that are important in that are looked at very heavily in breast cancer. Like cancer measurements, what does it mean? There is a concept that's collected called the number of lymph nodes positive. What does that mean? As well as, say, goes into some explanation of the types of breast cancer on the histologic, morphologic, and molecular levels, because there are different ways to classify these tumors. Okay, so this section does contain one example of how to model immunohistochemistry results for estrogen receptor status. And it does go down to one thing this is similar to what's in the implementation guide, version 3.2 in the MI domain. But this team has gone and broken the specifics of the methodology of this assay a little bit more using the MI test detail variable. Okay, so this is one example. This is one, in the prior treatment section, there is an example CRF that's been provided. There are a few things that I've circled here that the team has worked on. So one is defining control terminology for radiation type. There's some control terminology for that now. And also defining the relative location of where the radiation was given. I think I might have mentioned earlier that there's a concept of a relative location in addition to anatomic location in oncology earlier. And there's a controlled terminology for this too. So this would be one of these non-standard variables for which there is now controlled terminology of primary, regional, and distant. And one more thing that was introduced is how to collect cumulative dose. This is, the team spent quite a number of hours on how to represent this. And the blue text is what is represented in the CDISC, is what's collected using CDISC, and the red text is what it would translate to in SDTM. Okay, and this section for prior treatments also, not only does it include the example CRF, but it also includes how would that CRF, parts of that CRF be translated into SDTM. And the thing is, in the document it mentions this, but the example CRF is not something that is meant to be all collected, but it's a representation of things that can be collected, and sponsors are free to choose parts of it, but does not have to implement all by any means. Risk factors, they're just some textual descriptions of some risk factors in the document. Another concept map for treatments. Example, in the tumor identification assessment and disease response section, we have an example CRF. There is also a example SDTM tables, but they're pretty much exactly the same as what's published in version 3.2 IG. And one thing, the final one I wanted to point out is disease recurrence, because this is a new concept that we did model and have examples for in the document. So cancer can recur, and so when recurrence is, when it does recur, how can we model this? So the disease recurrence example, here you can see that a CT scan was given to this patient in the chest, and that there was a disease recurrence was observed in locally in the breast and lymph node. And we've introduced a new tumor test code called disease recurrence relative location again with controlled terminology. Okay. So there's some known issues in this document. One is, and these are all things that are missing in terms of modeling, and one is, I mentioned earlier, AJCC staging information is not modeled. There's no guidance on how to model pathology and histology. Treatment regimens, combination therapy that go across domains, not just within a domain. How do you represent if treatment is first-line therapy or second-line therapy? Some people record this, but some people derive it. And scoring methods for example, the immunohistochemistry example I showed you earlier. So our use case, Illumina. I'm not sure if everyone knows who we are, but we are the manufacturer of sequencers. In-house, we have a lot of data and we are using SDTM as a model to harmonize our data across data sets from different therapeutic areas even. Our major use case, as you can imagine, we have information coming out of sequencers, so our major use case is actually to tie together biomarker test results, pathology information, and biospecimen information. This is very important to us, in addition to the clinical records. So a few challenges we've had is, so we have a lot of biospecimen information. This we capture in the pharmacogenomics domains. ER/PR positivity is, if it's at the protein level, we're capturing it in MI. HER2, if it's at the protein level, we're capturing it in MI. If it's done using in situ hybridization, we're asked to use the PGX-IG, even though it might be the same specimen. And tumor identification result information we collect in TU and TR. And there are a few things. We always go back and forth. I mean, it's like, are these tests, aren't these all lab tests? And aren't these all part of tumor identification or results? So we always go back and forth, like, where do we put these results? So where do we logically put the data? And how can we collect simple information, like this is a primary tumor, this is a recurrent tumor, or metastatic? And we also we try to retain the no information. For example, was a tumor identified, yes or no? And we like to retain that negative information as well. And there's no good way to do this that we know of right now. And so this is the wish list. So, mechanism for capturing histology irrespective of location. We have a mechanism to capture location irrespective of histology. So we'd like to capture histology irrespective of location so that we can do cross-cancer studies. This is a known issue in the TUG, but staging, of course, and integrated use case examples that encompass both clinical and molecular data. Clearer guidance on how to capture baseline information, as well as collecting negative information. And that's it.
Any questions?
Some of this information goes to well-established domains, like medical history, procedures, general tumor domain. So how do we decide, how do we model these?
Oh, how do we model that? So those are things that I believe has been not, so one of the things when the user guides are developed is to not repeat information that's already in the main implementation guides, because if there's a change, then you have to propagate the changes in multiple documents. So what's already in the major implementation guide has not been, is on purpose not modeled in the therapeutic area user guide.
Very confusing.
And so we're going to move on because it's now 4:30, and thank you for sticking around. We said it was going to be over by 4:30 with a panel discussion at the end, but we still have one more to go, and this actually is, you know, from my point of view, is one of the more interesting ones. So, so please stick around for this one if you can. And let's get this going here. So we should welcome Jonathan Chainey, because he's only been in the Bay Area for what, since August?
That's right.
Okay, we need to do
and
this.
Thank you for setting me up for failure by saying this would be the most interesting presentation of the day.
Hang on.
Thank you, John. So maybe thank you for sticking around. I guess I'll try and keep it relatively brief and maybe go till 4:45 or something. Does that sound good? Okay. So maybe before I get started on my presentation, I'll just a couple of points that I guess John alluded to is, firstly, I'm the incoming chair. Is that better?
Get pretty close to it.
That sounds like it's going to be bad for my back, but I'll do my best. How about that?
It'll get to wherever you are.
Thank you. So I'm the chair-elect of the CDISC Advisory Council. So I imagine many of you know Sue Dubman quite well from UCSF. So I'm partnering with Sue in that role at the moment, as Sue is the current chair of the CDISC Advisory Council. So if any of you here are happen to be on that council, then I'd love to meet you before we all leave later today. But also, if any of you are from Platinum members of CDISC and don't know who your CDISC Advisory Council member is, then I encourage you to go and find out and maybe have a conversation with them and make sure that you are having a voice on that council. The second thing I just quickly mention is I think I wanted to clarify a question that Rhonda asked me in the middle of her presentation earlier around asthma implementation, and it was actually a user guide that we were heavily involved with at Roche Genentech, but I guess timing was a little bit against us, where we stepped away from that disease area around the time at which those standards became approved. So we haven't actually road tested those yet at Roche, but hopefully we will do in the future. Okay, well with that, I'll just maybe focus a bit more on the topic for today. So John asked me if I would talk about applying data standards governance in a pharmaceutical organization, and really how that relates to all the work going on around extending CDISC across multiple therapeutic areas. So that's what I'll try and do in, I guess, the next the next 10 minutes or so. But what I thought I would do is just provide some context first before diving into that specific question, and really just share the long-term vision that we've had at our organisation for a couple of years now. And if there was one slide that I could use to share that, that would be it. And that's basically something that I guess was inspired by sitting in the audience at a CDISC European Interchange back in 2011 in Brussels, where the CTO of CDISC at the time was talking about share and what the vision was for share. And he shared something very similar to this that then I think got myself and others at our company thinking about really preparing for the expected regulatory expectations around CDISC standards, and starting to really build that vision out step by step. So this slide is something that people in the audience from Roche or Genentech probably haven't, are not looking at for the first time, but I think it's something that's serving us very well. It's just a sort of a one-slide depiction of what it is that we're trying to do when it comes to clinical data standards implementation in a large pharmaceutical organization. So if I just sort of, hopefully most of it's fairly intuitive for the audience, but I'll just quickly walk you through it. So on the left-hand side, we have just some example external knowledge sources, and the key one here clearly is share. And when we first put this slide together, it was actually, you know, share was again a vision at that time, wasn't a reality. And I'm happy to say that it is now, and we are, I guess, getting close to release 3 of share. Can I put that down? And so, yeah, I think that's great progress to see that is becoming a reality. I think it is a great step forward. I think it's going to help the industry tremendously to implement CDISC in the future, mainly because I think we've been living in a PDF, Excel sheet, if you're lucky, world for far too long. So I think having the standards in a, let's say, a human and machine readable format for the industry is a huge step forward. So that's beneficial in itself for share. I think the other point that I hope comes across in this slide, and I'll talk to this, I guess, throughout this short presentation, is the importance of having a cohesive set of clinical data standards from beginning to end. From beginning to end, what we really mean there is ultimately right the way from our sort of clinical development plans right the way through to the individual submissions that we do related to those clinical development plans. And clearly we're a long way from that. I think we're a long way from that as a company, I guess, but as an industry, I guess we are. But I think it's something that we've used this slide both to understand where their work fits in relation to everybody else's in this space. We've used it to help explain to senior folks in our organisation what it is we're doing and why, and what the benefits might be of doing this. Yeah, it served us very well. So it's something I think we do continue to use this slide quite often in internal and external talks about the work of implementing CDISC in a large organisation. So just quickly to mention, before I go specifically onto the governance topic, and I know this isn't really a technology talk, but I would say, you know, there's 2 things that underpin everything we do around CDISC implementation at Roche Genentech. One is governance, which I will talk about in just a moment. The other one is technology. So you cannot do this work, in my opinion, without really having a really thoughtful, robust technical solution in place. And so the foundations we've put in place for our own internal MDR, which is in production now. It has been, we're at release 6 of that MDR. And to, I think, one of the ladies' points in the audience earlier, whilst Share isn't using RDF as a foundation, we are using it at Roche. It's where we've decided to use that W3C standard to underpin all of the content in our MDR, and that's serving us very well. I'm happy to talk at some other time to anyone in the audience that might be interested to hear a bit more about that. But I think it's been an interesting technological kind of approach we've taken here that I think is helping us an awful lot to really link information from how it's first conceived as a concept, perhaps, but then how that concept is represented in a protocol, what metadata then describes that concept in its collection, its tabulation, its analysis, what are the control terms associated with that. This RDF approach is helping us tremendously to do that sort of work and actually create a single source of the truth, if you like, for those things that you can use over and over again. So I think that's something we all continue to invest in and is serving us well in this space. So So in terms of our long-term vision for all of this, we're about halfway, I would say. We've got that MDR in production. We started to build out some genuine sort of automation related using that metadata in a structured way. And next year we're about to launch an application that actually connects the schedule activities in the back of the protocol with the study build process, and eventually then look to automate the SDTM mapping as much as possible as well. So if you're interested in any more of that stuff, then we're in the process of submitting abstracts to Fuse FDA, the CSS next year, as well as the CDISC interchanges both in Europe and in the international one later in the year. So hopefully I will have, or someone in my team will have some good news to share with you about all of that. So coming back to the governance topic, so as you can read on that statement, I think for us it's really been important. It's been so crucial for us to really put in a thoughtful governance model in place to make sure that all the different stakeholders that have a say and have the expertise that we need to go on to make sure that our standards are fit for purpose, those voices are getting heard. So here's again a one-slide depiction of an awful lot of work, but essentially this didn't happen overnight. This is the structure of our governance committee organisation. Many of the folks in my team actually lead those core teams here in the centre that you can see here across these different process areas. So we have really experts in those different process areas meeting pretty much weekly to discuss requests coming from our study management teams about how to apply the standards that we have already in place and maybe help us to understand if there's a requirement for something we haven't defined yet. You know, that's really the purpose of that governance committee. It's a very active committee. The core teams and the therapeutic area standards expert teams are where I would say the heart of the work is being done on an almost daily basis. So those TAs, as you can imagine, are the TAs in which we conduct our clinical trials across the world at Roche Genentech. And within each of those, although it's not shared here, we have, as you might expect, a clinical scientist, a biostatistician, a data manager, a programmer, someone working in these specific areas that really can be our go-to for decision making around those particular areas when it comes to data standards, questions and so on. So I hope this then brings it and loops it more relevantly into the conversation for today around the therapeutic area user guides, because by having those teams in place and actually have an expectation that they are part of that committee and they have a responsibility to actually reach out to their own colleagues perhaps if they don't have the answer themselves, by having that network already established and up and running, it makes our lives tremendously easier when it comes to being part of the CFAST activities, who's going to participate in a particular working group at the CFAST level that is a disease area which we're interested in, who's going to review that content that's coming from those therapeutic area user guides, for example. This is a hugely important entity for us, and we'll continue again to invest in governance like this as well. So I won't say too much more about this slide other than the advisory board I think is also very important. It helps us to have that senior leadership, let's say, support for what we're doing. It's an escalation path if we ever need it to make decisions around certain things. That's very rarely used, I'll be honest, but I think the advisory board is there really to help make sure that the resources are available across those different parts of the organisation. So for Roche, we have one product development organisation. We have two development organisations from legacy Genentech and legacy Roche, if you like. We have medical affairs, both US and non-US, to make sure we're involved here. We have diagnostics, we have finance, we have informatics. So it's pretty much an enterprise-wide board. It meets quarterly or as needed, but it's very, very helpful to make sure that we really do have the right input from the right people at the right time. So as I sort of already alluded to, I think once we've got that in place, then we feel now we're in as a big organisation like we are, maybe many of you come from much smaller companies, but for us we really needed to do this to get organised in order to have a coherent voice, let's say, from our company when it comes to working with CDISC or Transcelerate or through CFAST and so on. So just a couple of points I wanted to share on here. It was really what our approach has always been, be very much involved with what's happening at the CFAST level with therapeutic area standards development. Look to be involved where it makes sense. We are a member of Transliterate, so that gives us one means to be participating. But of course, even if we weren't, I think as a CDISC member, everyone, to Rhonda's point, has an absolute right to volunteer and be part of these efforts moving forward. So I think anyone in the room that's working in these areas should definitely, and the ones coming next year, should really think about influencing people in their company to be more actively involved here. Because to Rhonda's point, there are different skill sets needed on these different working groups. It could be a scientific need, it could be a metadata developer, and I don't know about you, but we don't have that as a job title as such at Roche, but we have people maybe doing similar type of work to that. So trying to help the CFAST effort and fit the right skill sets to the needs that they have, I think is a really important role for anyone that's got an interest in making CDISC be effective. And I guess the point below is just to be part of the solution and not to sit back and wait for somebody else to do it, the work, but actually be actively involved in that and to, I think, influence that from all the angles and make sure that at the end of the day, what is defined is going to meet your needs as a company. I realise I'm already overrun by 2 minutes, but I think this is my last slide. So this was just a couple of points around main challenges, really. I can see this a bit better in the sense. So I think we could all maybe debate whether the lines here are in the right spot for these different areas across, in terms of the extent by which CDISC provide the standards today in certain areas, and where a company like ourselves is currently extending those standards for making sure that we can at least get our own house in order, if you like, in the disease areas in which we operate. But this is just sort of my own, finger in the air kind of estimation of where we're at in terms of the current therapeutic area user guides that have been developed so far. And I think there's been an awful lot of progress made actually in recent months, and just hearing from Rhonda today and about the breast cancer therapeutic area user guide, I think we're getting a lot better at this. I think we are seeing now in breast cancer and prostate as well, using SHARE as a platform next year, where there will be a lot more of an emphasis on truly kind of beginning to end standards, and for protocol, even if it's just the objectives and the endpoints, I think that's going to help us a lot to join the dots and help our organizations implement these standards. CDASH is an area that I would love to be in a position to say one day, you know what, we're completely CDASH compliant, we've implemented CDASH at Roche. At the moment, there are internal constraints preventing us from doing that, but I think there's also, there's an opportunity there as an industry to really get behind CDASH, to make it really fit for purpose, because I think that's not just helping the pharma companies, I think that's going to help the investigators and the sites tremendously. And it will bring that transparency that we all hear about all the time from the regulators that they want to see from protocol right the way through to submission. I think without CDASH, every company right now is going and looking to maybe take SDTM and the concepts and fill the gap in between themselves. And I think maybe it's better that we do that as an industry together. I'm encouraged by the comments, I guess, earlier that Rhonda shared and others about really looking to focus on all of these aspects of the standard. Don't see that you've defined something until you've really got it defined from beginning to end. Just finally, a couple of final points I can do for myself here. But one is the TA specifications. Again, this is kind of slightly, I'm calling this out as a challenge, but now it's great to hear that the TA specifications are coming. I think what goes into the FDA data standards catalog is exactly what we will lean heavily on at our company to make sure that we make sure our standards meet those requirements. So I think not having to, let's say, pull that information out of a PDF document, but having it in a specification is going to be hugely beneficial for us as well. In the interest of time, I'm actually going to stop there. You can probably read the last couple of points already, but I'll maybe hand it over to any questions.